Hello guys, am I visible? Is it coming? Okay. Welcome back guys. Now this is the last session for the rapid revision of the physiology. Now in this class, let's do the leftover topics. So many students are asking me about the nerve and muscle physiology. What are the important topics which you should know for the nerve and muscle physiology? That will be discussed in this last session. Okay. If you have any doubts, you can all the time keep it in the chat box. Okay, I will try to answer as many as possible. So in this class, whatever the leftover topics, the muscle physiology and nerve physiology, mainly we are going to concentrate on the nerve physiology and muscle physiology. Also important MCQs, okay, which were asked from the respiratory physiology as well as the central nervous system. Whatever the leftover things are there, that will be discussed. Okay, just stay for the next 3 hours. 100% I can assure you, from muscle physiology 1 question, nerve physiology 1 question, central nervous system, respiratory, at least 4 to 5 questions will be coming. At least to least, you will get 4 MCQs for sure in the upcoming FMGE exam. No doubt in that. Okay. So stay with me and let's complete the topics. Okay guys, let's begin the show. Now, let's begin with the muscle physiology. Okay, the muscles which are helping in the contraction. The first type of muscle which I am going to discuss here is a skeletal muscle. Why is skeletal? See, we know there are skeletal muscles, smooth muscles as well as a cardiac muscle. There are three types of muscles. Why skeletal muscle is called as skeletal muscle? Simple, you know, because the muscles are attached to the skeletons, right? Now, in this skeletal muscle, okay, I will try to be a little slow. If you have any doubt, you can all the time ask me in the chat box. I will try to be slow. See, this skeletal muscle, you are looking the skeletal muscle over here. Now the muscle, okay, I'm showing you the muscle. Inside the muscle, see, there are a lot of these bundles present. What exactly are they? So inside a muscle, you are having fascicles. Okay, fascicles are present within the muscle. Okay, lot of fascicles are there. Now inside these fascicles, even you look into the fascicle, even there are a lot of these bundles present. So what exactly are these? These are the muscle fibers. So inside a fascicle, there are muscle fibers. Actually, these are the muscle cells. The real muscle cells are this muscle fibers. Okay, the myocytes, the muscle fibers are the real cells. Okay, now inside this muscle fiber, okay, this is the muscle fiber, no? Okay, this is the muscle fiber. Inside the muscle fiber, what do you have? You have the myofibrils. Okay, you have the myofibrils. So what is the order? Muscle, fascicle, muscle fiber and myofibril. See, I am showing you one myofibril here. You know, this is the skeletal muscle. Inside the skeletal muscle, what do we have? Fascicles are there. Inside the fascicles, what do we have? Myofibers are there. Inside the myofibers, we have myofibrils. Now, if you look here, see, this is the myofibril. Now, in this myofibrils, sir, I should say, sir, what exactly are these myofibrils? Okay, what exactly are these myofibrils? See, these myofibrils are nothing but the actin and myosin. Okay, inside a muscle fiber, okay, look here. Inside a muscle fiber, you have myofibrils. What are these myofibrils, sir? Myofibrils are nothing but actin and myosin. Okay, so this is just for your understanding purpose. No questions will come. Simple. Muscle, fascicle, myofibers, myofibrils. Myofibrils are nothing but the actin as well as the myosin. Okay, now after this, what you should know? Here the same thing was given. Muscle, fascicle, myofibers and myofibrils. What are these myofibrils? There are two types of myofibrils. Are these myofibers? Yeah, myofibers have the myofibrils. There are two types of myofibrils present, which are called as the myofilaments. Okay, these are the intermediary filaments, which are nothing but the actin as well as the myosin. Okay, no one will ask you in that detail. Simple. What they will ask you is, look here. So, in this myofibril, actin and myosin are there. No, if you look here, there is a Z line. Okay, let me show you here. There is a Z line and there is a Z line. So in between these two Z lines, whatever the area is present with the actin and myosin, center here is the myosin, this is the myosin, and here the blue color things are the actins, this is an actin, okay, the blue color things are the actin, and whatever I am highlighting here, this is the myosin. So myosin and actin are there, no? So this area which is present between, okay, see this is one Z line and this is the other Z line. So this area in between the two Z lines is called as a sarcomere. Okay, sarcomere. And that sarcomere, first MCQ, the functional unit of a muscle is called as a sarcomere. MCQ. So what is the functional unit of a muscle? The functional unit of a muscle is called as a sarcomere. And where exactly is the sarcomere present, sir? Sir, the sarcomere is present between two Z lines. Two Z lines. Okay, it's between the two Z lines. Done. Now, these are the questions which were asked previously. What is the thick filament? In the sarcomere, there is a thin filament, there is a thick filament. So what is the thick filament? The thick filament is called as the myosin. Okay, in the center I have shown you, right? So these are the myosins. Now, whatever I am highlighting, these are the myosins. So myosins are considered as the thick filaments. And what are the thin filaments? The thin filaments, say these red color things which are there over here. Okay, these actin filaments are considered as thin filaments. These actin filaments. Okay, so thin filament is actin. Okay, done, sir. Now, in the previous exam, this question has been asked. If you want to contract a muscle, yeah, the actin and myosin, they should interact. There is something called as a sliding filament theory, you know, right? So, what is the energy? It's an active process. Muscle contraction is an active process. So, who is giving energy? ATP is giving energy. ATP is being utilized. So, that's why it's called as an active process muscle contraction. Where this ATP is getting hydrolyzed, where the ADP is getting broken down into ADP and inorganic phosphate. Where? The myosin heads. Later I will show you. In the myosin, there is a head region. Myosin heads. The myosin head is containing this ATPase activity. So in the myosin head, ATP will be broken down into ADP. Okay, done, sir. Now here, okay, guys, is it everything clear? Arun, KK. Yeah, CNS and respiratory system will also be done. Okay, CNS and respiratory system, all the important MCQs will be done. This is the final class. Okay. Now tell me. Come on, guys. Is it everything clear? Shall I go forward? Okay. Now, look here. Concentrate on this. Okay, concentrate on this for a minute. Here, you already know, but let me tell you. The central things, here are the myosins. These are the thick filaments. Okay, these are the thick filaments. Myosins. Thick filament is a myosin. Now, what is this red color thing? This is the actin. Okay, actin as well as myosin. Okay, every student knows this. But the questions what they will ask you is, sir, this is the Z line, no doubt. See, this actin is attached to the Z line. Okay, actin is attached to the Z line with the help of which protein? That one thing they will ask you. Second thing, are you able to appreciate this little yellow color thing which I am highlighting here? Okay, which is shown there as little blue color, bluish color. Okay, so this one. Okay, so what exactly is this? Which is present along the length of the actin. There is something which is present along the length of the actin. That you should know. What is that? Third one which I want you to know is, sir, look here, the myosin, the central things. Myosin, it is getting attached. This myosin, it is attached to two places. One thing, the myosin is attached to this M band in the center. Okay. And the myosin is also attached to this myosin with the help of this blue color substance. It is attached to Z lines. So what is this blue color thing? We'll discuss one by one. Okay. Now, first fellow which I want you to know is the actin molecule attachment to the Z line. Actin molecule attachment to the Z line is with the help of a protein called as alpha actinin. Alpha actinin binds the actin thin filaments to the Z line. Done. Okay. Second fellow. Sir, what the hell is this? A titin. Okay, titin. See, titin, regarding titin, even recently the question has been asked. Titin is considered as a spring, muscle spring. It is the one which gives the elasticity to the muscle. The elasticity. Okay, recurring back. The elasticity to the muscle is because of, elastic properties are because of titin. Titin is the largest protein in the human beings. And the one more point about the titin is myosin is there, right? Myosin in the center, myosin is there. This myosin is attached to the Z lines is with the help of this titin. Okay, the blue color thing which I have shown here. Look, where is it? See, here titin is there. See, this titin molecules on one side they are attaching to the myosin. This titin is attaching the myosin to the Z line. Okay, titin, elastic properties. Titin, the largest protein in the humans. Titin attaches the myosin to the Z lines. Okay, what is alpha actinin? Alpha actinin, it attaches actin to the Z line. Done, sir. Okay. Next, guys, is it clear? Shall I go forward? Come on, Arun, Jenny, KK. Shall I go forward? Am I going fast? Do you feel am I going fast? You feel so? Please let me know. Okay, titin, it's the largest protein. The largest gene is the dystrophin gene. Okay, largest gene in the human genome is the dystrophin gene. But what is the largest protein? The largest protein is the titin. Okay, now titin is the one which gives the elastic properties to the skeletal muscle, and it is considered as a muscle spring. Muscle spring. Okay, now what this titin is doing, already taught you. Titin, it attaches the myosin to the Z lines. Answer. Done. Now the opposite thing, sir, myosin is there. The myosin is attached to the M line. What is that? Look here. See, this myosin in the center, it's there, no? Look here, guys. This green color fellow, it is attaching to this M. Okay. See, this myosin is attached to the M line. Myosin to M. M to M. Simple. It starts with the letter myomycin. M. Same letter. So, myosin, it is attached. Myosin attachment to the M line in the center is with the help of myomycin. Okay. I have discussed about the alpha actinin. Okay, alpha actinin. I have discussed about the titin. I have discussed about the myomycin. Myomycin attaches the myosin to the M band or the M line. Okay, it's the M line. Okay. Next. Then what is this a nebulin, sir? Something looking like a nebula from the Avengers? No. See, this nebulin, what is the importance? I have already taught you there is something which is present along the actin. Okay, there is something here I have shown you. See, this one. Okay, this guy, which is present along the length of the actin. See, this guy is nothing but nebulin. So, what is the importance of this nebulin, sir? Okay, some students might confuse it as, sir, actin, it's having the troponin, tropomyosin. Yeah, this is not the troponin or tropomyosin. This is something different. Now, this is called as a nebulin. It is present along the actin. It is present along the actin. What is the function? It regulates the length of the actin. The length of the actin filaments, okay, after the contraction, the length of the actin filaments is regulated by nebulin. Alpha actinin 4 completed. Myomycin is completed. Next, titin completed. Now, nebulin is also completed. Done, sir. Done. Next, desmin. In the muscle, not only those proteins whichever I have discussed, there are certain other proteins, okay, which are present in the muscle membrane, okay, like dystrophin. These things are there. In your exam, these are repeatedly asked. I am just getting little deviated. See, there is a protein in your muscle membrane, in the sarcolemma. Okay, in the sarcolemma, in the muscle, there is a muscle cell myocyte or muscle fiber is there. Okay, myofiber is there. Now, these myofibers are also having the cell membrane, right? Now, in this cell membrane, there is a very important protein. This I am highlighting even in the last classes, which was the question asked in the last FMGE exam, 2022 FMGE exam. Okay, this question was asked. See, there is a protein called as a dystrophin. It is a peripheral protein. In the general physiology also I have discussed this. This is not an integral protein. This is a peripheral protein called as a dystrophin. What is this importance? The dystrophin, it gives the tensile strength to the cell membrane. It gives the tensile strength to the cell membranes. If the dystrophin, if it is a defective, it is going to cause Duchenne's muscular dystrophy. Okay, sorry, the word I should use is absent, complete absence, not just defective. If it is defective, it will cause Becker's muscular dystrophy. If this protein, if this dystrophin, I will show you the image also. If this dystrophin, it is completely absent, then it is going to cause a disease called as Duchenne's muscular dystrophy. Done. Next, one more protein is there which is called as a desmin. Okay, desmin. What is this desmin? See, this desmin is an intermediary filament. Okay, desmin, it's the intermediary filament. It's an intermediary filament. You know, right, in last class, in the cytoskeleton topic, in the cytoskeleton we have discussed, there are microfilament, intermediary filaments. Okay, in the topic of intermediary filaments, there also I have discussed desmin. Where it is present, sir? This desmin, it is present in the skeletal muscles. Desmin, it's an intermediary filament present in the skeletal muscles. Okay, now this desmin is considered as, questions asked from pathology and physiology as well. This desmin, it is considered as a marker of rhabdomyosarcomas. Okay, rhabdomyosarcomas means what? Rhabdomyo means skeletal muscle. Sarcoma means the cancer. So, rhabdomyosarcomas. For the rhabdomyosarcomas, the tumor marker is desmin. What is desmin, sir? Desmin is an intermediary filament present in the skeletal muscles. Okay. Okay. Now, is everything clear? Okay. Come on, guys. Whatever we have discussed about desmin as well as dystrophin. Okay. Now, let me discuss about the dystrophin a little in detail. Okay. Why? Because this is a very, very important question. Okay, which was tested in the PG exams. This is going to be the last FMGE exam. You should not take it you should not take it granted. You should not go to exam without preparing. So, listen. This area is very, very important. Now, what is this area, sir? Now, here I am talking. Whatever I am showing you, look at this. This is the membrane. This is the membrane, cell membrane. Also called as a sarcolemma. Sarcolemma, the muscle cell membrane. Okay. Now, in this muscle cell membrane, are you able to appreciate some integral proteins are present? Means throughout the cell membrane, some proteins are present. Some integral proteins are present. Some peripheral proteins are present. See, this is a peripheral protein. This is one peripheral protein. So, what are these integral proteins and what are the peripheral proteins? Simple. Look here. First protein which I am discussing is, are you able to appreciate this violet color one? See, alpha subunit, beta subunit is there. Alpha subunit, beta subunit of what? What is the name of this integral protein? This integral protein is called as a dystroglycans. Okay. Dystroglycan is one integral protein. Okay, sir. Next, see, there are these blue color integral proteins which I am highlighting here. These are called as a sarcoglycans. Okay, there is a dystroglycan as well as sarcoglycan. Okay, sir. So, the same thing which I have shown here. See, in the muscle cell membrane, the sarcolemma, there is dystrophin. Sorry, first, let's come from here. There is a dystroglycan. See, it is a IP. IP means integral protein. First, I am talking about the integral protein, means which is passing through the cell membrane, integral protein. And there is sarcoglycan. Okay, dystroglycan is there, sarcoglycan is there. Next, what are the peripheral proteins? See, attached to this dystroglycan, are you able to appreciate this dystrophin? See, this red color thing. Okay, let me show you with the red color only. See, this fellow is a dystrophin. It is getting attached to dystroglycan. Okay. And there is this green color thing, which is a peripheral protein. Again, it's present only on one side of the cell membrane. It's present only on the one side of the cell membrane. That's why it is called as a peripheral protein. So, this is called as the syntropins. Okay. Syntropin as well as dystrophin. So, syntropin and dystrophin, they are peripheral proteins which are present inside the cell membrane. And what are the two integral proteins? The two integral proteins are dystroglycan, sarcoglycan. Okay. So, these are the points which I want you to know. There is one more protein which is also which is called as a sarcospan. Here the last fellow is there. No, this is called as sarcospan. Not that important. Okay. So, at least I want you to know, sir, two integral proteins are there. What are the two integral proteins? Dystroglycan as well as sarcoglycan. There are two peripheral proteins present. What are the two peripheral proteins? Dystrophin as well as syntropin. That's it. Question which was asked in one of the Central Institute exams is, if there is any problem with dystrophin, you already know the disease. If there is absence of this dystrophin absence is going to cause a Duchenne's muscular dystrophy. Okay. Next, if there is any defect with the sarcoglycan complex, Okay, here there is sarcoglycans, no, these fellows. Okay, this integral protein. If there is any defect in this sarcoglycan, then it is going to cause limb girdle muscular dystrophy. So limb girdle muscular dystrophy, previously asked MCQ, limb girdle muscular dystrophy is due to problem in where? Sarcoglycans. Sarcoglycans are integral proteins. Done, sir. Completed. Okay. Next, what else you should know? Same direct questions which I want you to know are normally during resting state, muscle is not contracting. Okay. So actin and myosin, they are not interacting. Why? Why? Because on the surface of actin, what do you have? If, for example, imagine this is actin. Actin contains the active sites. Okay, actin contains active sites. But these active sites during resting state, they are closed. They are closed. The active sites on actin, they are closed, sir. By whom? By whom? By tropomyosin. So, the number one MCQ point which I want you to know is there is a regulatory protein. Okay, this is a regulatory protein which is called as a tropomyosin. What this tropomyosin is doing? When the muscle is not contracting, when the muscle is in resting state or inactive state, this tropomyosin, it blocks the active sites on actin. Okay. Next important regulatory protein. The next important regulatory protein is called as a troponin. Okay, troponin. There are different types of troponins, but here I am talking about the troponin C. C for calcium. What I want you to know is C. Array, look, understand. Here I am showing you actin. Okay, imagine actin is actually made up of globular actins, but here I am showing you, imagine this is actin. Okay, actin. So on the surface of actin, what do we have? See, on the surface of actin, we have active sites. Okay, active sites are there, to which the myosin heads will go. See, the myosin heads will go and bind with the active sites. Okay. Now, these active sites, they are closed by what? The active sites, they are closed by tropomyosin. For your understanding purpose, I am showing you like this. Okay, this is not anatomically correct, but understanding purpose, it is easy. There is something called as tropomyosin. Tropomyosin, what it is doing? It's covering the active sites. Okay, sir. Now, there is one more thing, one more protein which is present is called as troponin. Okay, imagine this is the troponin C. Okay, see what is this troponin C is doing? See, this troponin C, what it will do is it will bind with the calcium. Okay, whenever calcium binds with the troponin C, the calcium is binding with the troponin C. Now, do you know what this troponin will do? Troponin will bring the change in the tropomyosin. Whenever the calcium is coming and binding with the troponin C, now this troponin will move away, will bring the conformational change in the tropomyosin. So now tropomyosin is moving away from the active sites. So the active sites are going to be exposed. Simple point is calcium binds with what? Calcium binds with tropomyosin. Sorry, a troponin. Calcium binds with the troponin. Active sites are blocked by, the active sites on the actin are blocked by tropomyosin. Calcium binds with troponin. Done, sir. Okay. Now, after this, what else you should know? For the next 5 minutes, please be very attentive. This area is little tricky, but very high yielding. Okay, very high yielding. If they want to integrate, if they want to test you, really whether you are good or not, they will give the question from this area. Okay. Here, this membrane is sarcolemma. Sarcolemma. That's the muscle membrane. This muscle membrane. Okay. Now I am talking about one muscle cell. Okay, myofiber. Look here. Now I am talking about what? This one. Okay. Now I am talking about this one muscle fiber. Now in this one muscle fiber I am showing you. Look. This is one muscle fiber. Now this muscle fiber, it is covered by what? It is covered by this sarcolemma. Now this sarcolemma, look, it is having this invaginations. The sarcolemma is having invaginations. This invagination, whatever I am pointing here, this is called as T-tubule. So now tell me MCQ. So T-tubules are the invaginations of sarcolemma. There is one more tubule called as the L-tubule. So T-tubule, you know, MCQ completed. What is the L-tubule? Okay, The L tubule, this is longitudinal in nature. No, this is longitudinal. So that's why it's called as a L tubule. Sir, what exactly is this L tubule? This L tubule is nothing but sarcoplasmic reticulum. A sarcoplasmic reticulum. Aha, okay. In a muscle fiber, there is a T tubule present. There is a L tubule present. T tubule, L tubule present. T tubule is nothing but the invagination of the sarcolemma, and this L tubule is nothing but the sarcoplasmic reticulum. Sarcoplasmic reticulum. Very, very important MCQ is sarcoplasmic reticulum. It stores what? What is getting stored inside the sarcoplasmic reticulum? Sir, if you look inside the sarcoplasmic reticulum, what is present? It's a storehouse of calcium. Okay, MCQ. So sarcoplasmic reticulum stores calcium. Okay, sir. Done. Now, let me tell you the story. This is your neuron. Okay, this is your alpha motor neuron. Okay, alpha motor neuron means that neuron which will cause contraction of the muscles. Okay, then the muscles are innervated by the neuron. No, that neuron is called as the alpha motor neuron. It's simple. From your spinal cord, alpha motor neuron. From your spinal cord, alpha motor neuron is coming to your muscles. Now, this alpha motor neuron is activated. It is getting depolarized. Action potentials are happening. Now, what will happen? Sir, this alpha motor neuron, it is releasing which neurotransmitter? Sir, it is releasing acetylcholine, MCQ. So, what is the neurotransmitter in neuromuscular junction? See, this is a neuron. Okay. This is a muscle. Okay, this is a muscle fiber. No. So, in between a neuron and muscle fiber, there is a junction. There is a synapse. So, this synapse is nothing but the neuromuscular junction. So, MCQ is, what is the neurotransmitter in neuromuscular junction? Sir, it is acetylcholine. Acetylcholine. Okay. Now, this acetylcholine, look. Now, this acetylcholine, it is acting where? Sir, it is acting on this receptor. There is a receptor in the neuromuscular junction. So, what is the name of this receptor? This is called as nicotinic receptor. Okay, it is NM type of nicotinic receptor. Nicotinic receptor. So MCQ is what? Alpha motor neurons are releasing which neurotransmitter? Acetylcholine in the neuromuscular junction. Completed. See, this acetylcholine, it is coming and it helps in the muscle contraction. True, but how? This acetylcholine, it is coming and binding to which receptor? Nicotinic receptor, NM type of nicotinic receptor. Okay, sir. Now look here. Whenever this acetylcholine is binding here, what happens? The NM type of receptor is activated and now sodium influx is happening into the cell. Okay, sodium is coming into the cell. Now you know when sodium comes into the cell, positive charges are coming into the cell. Now the cell will start to undergo depolarization. Okay, so that's why whenever acetylcholine, okay, whenever this acetylcholine is coming into the muscles, whenever it's acting on the nicotinic M receptor, NM type of receptor, the sodium influx will happen into the cell. Now, because of the sodium influx, see, there is depolarization, activation. The cell membrane, the sarcolemma is getting activated, getting positivity. Now, MCQs. You should know what happens. How exactly muscle contraction happens is whenever this depolarization happens, what happens is, before knowing that, I should actually teach you two more things. Look on this T tubule. I have already taught you what is the T tubule. Imagination, T tubule. On the T tubule, have you appreciated this green color thing? Okay, this green color thing. Have you appreciated this? What is this? Channel. The channel which is present on the T tubule, sir. The channel which is present on the T tubule, this is called as DHPR. Dihydropyridine calcium channel. Okay, this dihydropyridine calcium channel, it is present where? It is present on T tubule. Okay. Okay, sir. Now look at the sarcoplasmic reticulum. Look on the sarcoplasmic reticulum. Are you able to appreciate this blue color channel which I am highlighting right now? The blue color channel is called as ryanodine receptor. Ryanodine receptor. So 2 MCQs completed. On the T tubule, what is present? DHPR, dihydropyridine calcium channel is present on the T tubule. Okay. On the L tubule, on the sarcoplasmic reticulum, which channel is present? Ryanodine receptor is present. Now you will have a story. Sir, why we need to know all this? Now you will understand. See, first step, neuron is activated. Neuron depolarization happened. Okay. This neuron depolarization is releasing what? Acetylcholine. Okay. Now what this acetylcholine is doing? Acting on which receptor? NM type of nicotinic receptor. Okay. Because of this, what happens? Sodium comes into the cell. Sodium influx happens. Completed, sir. Now because of the sodium influx, the muscle membrane, the sarcolemmal membrane undergoing the depolarization. Now see, depolarization, this depolarization is doing what? It is activating the dihydropyridine receptor. Now it's activating what? Dihydropyridine receptor. Okay, which is also called as, see this CAV 1.1. Okay, you no need to remember the CAV 1.1 for FMGE exam. It's not that important. At least remember this dihydropyridine calcium channel is activated. Now see this dihydropyridine receptor. Now do you know what it is doing? It will activate. It will further activate mechanically. Okay, mechanically it will further activate this ryanodine receptor. Okay, if your friend is activated, he will activate you. Okay, try to understand like this. So once the dihydropyridine receptor is activated, it activates what? It further activates ryanodine receptor. Now sir, see, once this ryanodine receptor is opened because of the DHPR, DHPR is causing the conformational change in the ryanodine receptor. Once the ryanodine receptor is opened, do you know what happens? The calcium, all this calcium which is present, okay, in the sarcoplasmic reticulum, it will start to come out. Now you know this calcium is the one which helps in the contraction of the muscle. So which ion is needed for the contraction of the muscle? Calcium. Okay, so important topics are completed. Now the important topics regarding this topic, this particular area. So now tell me, for the muscle, skeletal muscle contraction, which type of neurons are needed? Alpha motor neurons or gamma motor neurons? Which neurons? Alpha motor neurons. Okay, alpha motor neurons are needed for the skeletal muscle contraction. Next thing, what is a neurotransmitter in neuromuscular junction? In the neuromuscular junction, the neurotransmitter is acetylcholine. Acetylcholine is acting on which receptor? NM type of nicotinic receptor. On the T tubule, okay, on the T tubule, which channel is present? Dihydropyridine receptor or dihydropyridine calcium channel is present. Okay, DHPR is present on the T tubule. Once DHPR is activated, it will activate what? It will activate the ryanodine receptor, ryanodine calcium channel. Okay, but this ryanodine receptor, where it is present? So the ryanodine receptors are present on the L tubule, nothing but sarcoplasmic reticulum. Once the RYR is activated, calcium will come out of the RYR, helps in the contraction of the muscle, or helps in the sliding of actin over the myosin. Done. Next, what else are needed? One single liner question is there. What is a motor unit? It was a single liner question, which I want you to know, just simple. Guys, is it clear? Am I going fast? Is it clear or am I going fast, guys? Love from Botswana. Right? Mori Kami, you are from Botswana. If you have any questions, you can all the time ask here. Come on, Arun, KK. Is it okay or am I going fast? Okay. Hope everything is clear. Now, see, what is a motor unit? It's a single liner question. Motor unit means nothing. Very simple. There is this alpha motor neuron, you know it, alpha motor neuron. See, this one alpha motor neuron, it's like a naughty guy. It's not satisfied with one muscle fiber. It's not satisfied. It's like a naughty guy. Okay, it's like a playboy. He is not satisfied with one muscle fiber. So what he is doing is he is innervating multiple muscle fibers. See, this is one muscle fiber. This is the other muscle fiber. This is the other muscle fiber. This is the other muscle fiber. So even in your muscles, one alpha motor neuron, whatever is going, this alpha motor neuron, it innervates multiple muscle fibers or multiple myocytes. Okay, so this is called as motor unit, one motor unit. So you should know what is a motor unit. Sir, one motor unit consists of one alpha motor neuron, with many muscle fibers. With many muscle fibers. Done. These questions already you know, no need for me to explain again. What is the storage site of calcium in the muscle? The storage site of calcium in the muscle is sarcoplasmic reticulum. You already know. Dihydropyridine receptors. Dihydropyridine receptors are present where? On the L tubule or T tubule? They are present on the T tubule. Good. Next, RYR, ryanodine receptors, ryanodine calcium channels. So the ryanodine calcium channels are present where? So they are present on the sarcoplasmic reticulum. Okay, they are present. See here I have written. They are present on cisterna. Okay, they are present on the cisterna of sarcoplasmic reticulum. You will have it out. Sir, what is this cisterna, sir? Simple, man, it's nothing. But look here, these bulged ends are there, right? These bulged ends, they are nothing but cisterna. Okay, so on the cisterna, you have the RYR channels. Okay, so these ryanodine receptors are present on cisterna of sarcoplasmic reticulum. Okay, in the exam going students, okay, next month, 31st, I think 30. You are having this exam, right? Have you studied your anesthesia? Now, in your anesthesia, you have studied properly. Certain inhalational anesthetic agents like halothane, desflurane, okay, and depolarizing muscle contractants like succinylcholine. Sorry, not muscle contractants, muscle relaxants. Sorry, okay. Same, there are certain inhalational and anesthetic agents like halothane. Okay, halothane, desflurane, succinylcholine, sir, muscle relaxant, succinylcholine. See, whenever you use these things, do you know what happens? Okay, do you know what happens? It causes a condition called as a malignant hyperthermia. Okay, so malignant hyperthermia. Tell me, it is because of usage of which inhalational anesthetics? Halothane, desflurane, okay, isoflurane. Now, the point which I want you to know is, in certain individuals, okay, in certain individuals, this ryanodine receptor is having overactivity. Okay, gain of activity because of mutation, gain of mutation, overactivity. So, whenever this ryanodine receptor is overacting, tell me what happens. So, ryanodine receptor is kept on working. This ryanodine calcium channel is kept on opening. So, calcium will be releasing out of the sarcoplasmic reticulum. So, this calcium will cause what? Sustained muscle contractions. Sustained muscle contractions are going to be there. Whenever muscle is contracting, ATP will be broken down, energy will be released, temperature will be released, you know, right? So, malignant hyperthermia. Okay. If this ryanodine receptor, remember, you know, where is this ryanodine receptor? But if this ryanodine receptor, if it is having gain of mutation, okay, gain of mutation in the ryanodine receptor gene, then it will cause a condition called as malignant hyperthermia. Okay, in these fellows, using of these drugs like halothane, desflurane and succinylcholine, in this particular fellows, if you use these drugs, okay, halothane, desflurane or succinylcholine, then they will develop malignant hyperthermia. Or if, for example, in normal person like me, if you use this inhalation anesthetic agents, nothing will happen. Okay, not a big deal. But if I am having some problem with the ryanodine receptor, gain of mutation with the ryanodine receptor activity, if you use this anesthetic agent, that will cause malignant hyperthermia. Now, what is the treatment? MCQ. The treatment for this malignant hyperthermia is a dantrolene sodium. Okay, dantrolene sodium is the drug of choice for malignant hyperthermia. Okay, it's a ryanodine receptor blocker. Okay, it's a ryanodine receptor blocker. Dantrolene sodium is a ryanodine receptor blocker used in the treatment of malignant hyperthermia. Completed, sir. Okay. Now, let me tell you certain questions which were asked in the PG exams. Okay, not just the FMG exams. These questions were previously tested in the NEET PG exams and the INICT exams. I don't want to take any risk. If you know this, it's better. Okay, there is no chance that you can miss a question. See this calcium 1.1. Okay, CAV 1.1 mutation. Sir, what is the CAV 1.1? This is nothing but DHPR, dihydropyridine receptor. Okay, DHPR. So dihydropyridine receptor. If we here, some students might have it out. Again, they will be confused. See, DHPR is also called as CAV 1.1. This fellow, which is present on the T tubule, which will be activated upon depolarization. Okay. See, this DHPR, if it is gone, if it is damaged, then it is going to cause a condition called as, okay, hypokalemic periodic paralysis. DHPR is not working. RYR do not function. If RYR do not function, calcium is not getting released, that will cause paralysis. Simple. Okay. So, DHPR mutation or calcium 1.1 channel mutation is going to cause hypokalemic periodic paralysis. Next, this sodium, okay, sodium channel. If this sodium channel, if it is mutated, now you will get it out, sir. What is the sodium channel, sir? Here I have written Na. Na means sodium. What is this? V stands for voltage gated sodium channel. Okay, type 1.4. Now you will get it out, sir. What is this? Voltage gated sodium channel. Very simple, Ray. Here, look here. See, here there is the sodium channel, no? The sodium channel. This is the sodium channel. Okay. Now, this sodium channel, once the nicotinic receptors are activated, they will allow the influx of sodium. Okay, they will allow the influx of sodium. So, if that sodium channel, okay, if this voltage gated sodium channel, if it is mutated, it is causing what? Hyperkalemic periodic paralysis. So, sodium channel defect will cause hyperkalemic periodic paralysis. DHPR channel mutation will cause hypokalemic periodic paralysis. Okay, sir, done. Next, these are, see, if you know them, it's better. If you can't remember, just leave it. Okay, no force. Next, SERCA. So, what is this SERCA and where it is present? Okay, let me tell you. SERCA means, first you should know, SERCA means sarcoendoplasmic reticulum. Sarcoplasmic endoplasmic reticulum. What is the sarcoplasmic endoplasmic reticulum, sir? Simple, this fellow. Okay, this fellow is the sarcoplasmic reticulum. Okay, here if you look, I have shown you SERCA. Sir, what is this SERCA? What it is doing? Whatever the calcium that is coming out, see, this calcium is coming out, right? The calcium is coming out and that calcium is helping in contraction. After contraction, what should happen? Relaxation should happen. Okay, the muscle should relax. During relaxation, we don't want calcium. We don't want calcium. All the calcium should go back. Okay, all the calcium should be again getting back, or it should be it should be getting back into the sarcoplasmic reticulum. By whom? Who will do that job? It will be done by SERCA pump. The SERCA pump. Sarcoplasmic endoplasmic reticulum ATPase. Okay, sarcoplasmic endoplasmic reticulum calcium ATPase. Okay, it's a pump. It's a pump. What it will do? It will help in the relaxation of muscles. It will take the calcium back into the, it will take all the calcium from the sarcoplasm, from the muscle. It will again all concentrate back into the endoplasmic reticulum or the sarcoplasmic reticulum. Okay, that is SERCA. Now, if this SERCA, very, very important, don't forget, SERCA is present on the endoplasmic reticulum. What SERCA will do? It will decrease the calcium levels within the cell. Okay, all the calcium will be taken back into the sarcoplasmic reticulum. Don't forget. Now, if such a SERCA, if it is gone means, if it is damaged means, it will cause Brody's myopathy. Okay, it will cause Brody's myopathy or Brody's, sorry, Brody's or Brody's. Okay, someone will say Brody or Brody. This Brody's myopathy, it is because of what? It is because of defect in SERCA pump. This SERCA pump, it is like, it's a protein which is coded by this gene ATP2A1. If this ATP2A1, if it is mutated, the gene is mutated, then SERCA protein is going to be, the SERCA pump is going to be defective. That causes Brody's myopathy. Done. So now, one by one, guys, tell me, ranodine receptor mutation, gain of ranodine receptor function will cause malignant hyperthermia. Okay, malignant hyperthermia. It is precipitated by halothane, succinylcholine, desflurane. What is the treatment of malignant hyperthermia? Dantrolene sodium. Okay, so defect in dihydropyridine receptor channel, DHPR mutation. DHPR mutation is going to cause hypokalemic periodic paralysis. Sodium channel defect, okay, voltage gated sodium channel defect, it is going to cause hyperkalemic periodic paralysis. This Brody's myopathy is due to defect in SERCA. Okay, SERCA pump. SERCA, what it is doing? SERCA is present on the L tubule. SERCA is present on the sarcoplasmic endoplasmic reticulum. It will take all the calcium back. It will pump all the calcium back into the sarcoplasmic endoplasmic reticulum, helps in the relaxation of the muscle. Okay, is it clear? Bill, Shishala Bill, Okay, you want me to talk about the myasthenia gravis? Definitely I will talk about the myasthenia gravis when I am doing the nerve. Okay, when I am doing the nerve, I will discuss about the myasthenia gravis as well as the Lambert-Eaton syndrome and botulism. The three integrations will be done in the nerve part, which will be coming in the next 15 minutes. Okay, so till here is it clear, guys? Shall I go forward? Now, there is this question which was asked in the last FMGE exam. This question was asked, okay, which will be coming in the next 5 minutes. 100% I am telling you, see, one question will be pakka coming from the muscle physiology. No doubt in that. One question from nerve and one question from the muscle. One question from the central nervous system, one question from the respiratory. At least 4 questions will come just from this one session. Okay. Next, let's talk about the muscle contraction. Okay. See, in this muscle contraction topic, you know, there is something called a sliding filament theory. What is the sliding filament theory, sir? According to the sliding filament theory, as this is the rapid revision, right? I am not going in detail. MCQs I will concentrate. Okay. First, there will be an actin filament. Okay. There is an actin filament. There is a myosin filament. Actin and myosin. Okay. Actin and myosin. The myosin have what? The myosin is having the heads. Myosin heads will be there. These myosin heads, they will go and bind with the active sites on the actin and will cause power stroke. Okay, and will cause a power stroke. Okay. So that will cause the contraction. That will cause the contraction of the muscles. You can very well see here. See, now first ATP is getting attached. ATP will be broken down into ADP and inorganic phosphate. So this myosin head, look here, the myosin head is going to go and bind with the actin. Okay. After this, what happens? See, there is a power stroke. Okay, there is a power stroke. Means the myosin head, it will bend and it will cause sliding. It will cause a sliding of the actin filaments. It will cause the movement of the actin filaments onto the myosin. So that will cause contraction of the muscle. Okay. 2 MCQ points which you should know for your exam. It doesn't matter whatever is the exam. FMGE, NEET, PG, NST, same question will be asked. 2 questions. What are these? Say, for power stroke. Power stroke means bending of the myosin heads. The myosin heads, they will go and bind with the actin. They are already binding. Okay. They will bend like this, causing the power stroke. What causes the power stroke? It's the release, not the binding of the ATP. Most of the people will think binding of the ATP is causing the power stroke. No. It's the release of ADP and PI that will cause the power stroke. So release of the ADP, it's causing the power stroke. Okay, the same thing, look here. See, during the power stroke, the myosin head bends and the ADP and phosphate are getting released. So during power stroke, what happens? ADP and inorganic phosphate are released. Okay, first MCQ completed. Next, after this, see, one thing. Now, the myosin heads, they have to go and bind on the active sites on the actin. They have to do the power stroke. After that, what should happen? This cross bridge, whatever is there, this is the cross bridge. The myosin head, it is going and binding to the active site on actin. See, this link is called as a cross bridge. Now, this cross bridge have to detach and the myosin head have to go and bind with the other active site. So, this cross bridge breakdown, this was the question. For the breakdown of this cross linkage, for the breakdown of this, cross bridge, what you need? New ATP, binding of the ATP. Remember, binding of the ATP will cause the breakdown or detachment of the cross bridge, or myosin head detachment. Myosin head detachment from where? From actin, active site. So what is needed? It's the binding of new ATP molecule. See, when the new ATP molecule is binded, now detachment will happen. Okay. See, the new molecule of ATP attaches to the myosin head, causing the cross bridge detachment. Okay. So now tell me, during power stroke or when power stroke happens, when the ADP and inorganic phosphate, whenever they are released, power stroke will happen. Next important MCQ, for the detachment of the cross bridges, for the detachment of the myosin head from the actin, what do you need? binding of the new ATP. Done. These are the two MCQs which you should never ever forget. In a basic way, we can say thick filament, thin filament. The thick filament myosin, it have myosin heads. Okay, this myosin heads. This myosin heads will go and bind with the actin, causes the power stroke, causing sliding of the thin filaments over the thick filaments. That's a muscle contraction. Okay, completed. After this, what is the next important area, especially for the exam, FMGE exam, NEET PG exam? This is the most important area. During muscle contraction, there are different lines. No, there is A band, I band, H band. So many things are there. In a sarcomere, if you concentrate here, guys, there is something called as M band. Yeah, look here. There is something called as M band, or M line is there, Z lines are there. These are the Z lines. Okay. Now, what happens to them? Okay, I hope most of you guys have already studied. Okay, what happens during muscle contraction? Both the Z lines, the sarcomere length decreases. Both the Z lines are approaching each other, so the distance between the Z lines decreases. Okay, so the question which they will ask you is, during muscle contraction, what happens? Z lines approaches each other. Okay, sir. And H band and I band, whatever is there in the sarcomere. In the sarcomere, there is H band as well as I band. Okay. Now, this H band and I band, I used to remember something like this. Hi, when I know some person, for example, I know this person. Okay, so for example, I know this person. What I will say? Hi. I will say hi. So when I say hi, I will go and meet him, right? So, or he will come and meet me. So the distance between us, what happens? Whenever we are meeting, what happens? The distance between us decreases. So simple. Remember in the same way. So H and I, hi. During muscle contraction, the H band size decreases and I band size decreases. Just like when I say hi, the distance between the two people decreases. Okay, we will meet together and we'll talk. So in the same way, the H band size decreases because of the sliding of the filaments. These zones, the size of these zones will decrease. The H band decreases and I band decreases. H band and I band, they are decreasing. Okay. Next, there is this A band, A for anisotropic region. So this A band, what happens to this A band? So A band, there is no change. There is no change in this A band. Okay. So direct single liner questions. I don't want to go in detail explaining about this. Simple. Z lines approaches each other. H and I, the length of the H band and I band decreases. And what about the A? This A band length is going to be constant. There is no change or constant. Okay, so done. Now after this, the main points which I want you to know is, now muscle contraction integration, integrated topics. Okay, for the next 10 minutes, please listen. These are integrated with the medicines, integrated with the pharma. Okay, pharma as well as patho. So how this muscle contraction it is integrated? Look here. What is this? This is the alpha motor neuron, you know it. This alpha motor neuron, what it is releasing? Sir, it is releasing acetylcholine. Okay. See, this acetylcholine, it is acting on when? It is acting on the acetylcholine receptor, which is NM type of nicotinic receptor. That's the acetylcholine receptor. The point which I want you to know is, see, this is the alpha motor neuron. Okay. Once this alpha motor neuron, it is getting depolarized, okay, it's activating. No, in the last region, in the last part. Okay, this is the nerve terminal, right? This is the nerve terminal. What happens is, when the neuron is getting depolarized, see, these calcium channels, okay, these are the voltage gated calcium channels. These voltage gated calcium channels, they are opened. MCQ, even this will come in the nerve physiology. Okay, there I won't teach you, here itself I am teaching you. When the nerve is getting depolarized, at the end part, in the terminal region, in the nerve terminal, this voltage gated calcium channels, they will open. And what happens? See, the calcium, it is coming into the cell. Okay, calcium will come into the cell. We know calcium helps in exocytosis. Calcium, it will come and bind with these vesicles which contains the acetylcholine. Okay, so these vesicles will come and fuse here, leading to release of the acetylcholine. So acetylcholine is going to be release itself. Okay, acetylcholine is going to be released, right? Now, what is the integration? There is a disease where this receptors, look here, what is this? Not receptors, sorry, these are the calcium channels, right? Voltage gated calcium channels, which are activated during action potential. When the action potential is coming, they will be activated, causes the influx of the calcium. There is a disease where, see, antibodies are getting produced. Antibody production again is the voltage gated calcium channels which are present on the alpha motor neurons. Okay, little complicated, right? I will explain you again. It's an autoimmune condition. There is an autoimmune condition where the antibodies are produced against the voltage gated calcium channels which are present on the nerve terminal of the alpha motor neurons. It's a disease is called as LEMS. Okay, Lambert-Eaton myasthenic syndrome, LEMS. So what is this condition, sir? LEMS. Look, there is a disease which is called as Lambert-Eaton syndrome or Lambert-Eaton myasthenic syndrome. What is happening in this condition? Antibodies are getting produced against what? Voltage gated calcium channel. Against the voltage gated calcium channel, antibodies are getting produced. So now do you think calcium influx will happen? No calcium influx will happen. Do you think acetylcholine will be released? No, acetylcholine is not released. So do you think muscle contraction will happen? No muscle contraction. So weakness of the muscles, paralysis of the muscles will happen. So that is the Lambert-Eaton myasthenic. Myasthenia means weakness of the muscles. So Lambert-Eaton myasthenic syndrome. Okay, one singular MCQ. In LEMS, Lambert-Eaton myasthenic syndrome, autoantibodies are produced against the voltage gated calcium channels on the neurons. Next, there is one more autoimmune disease. So like, some guy is asking the Bill. Okay, Bill, you are discussing about the myasthenia gravis, right? What exactly is myasthenia gravis? It is also an autoimmune condition. Okay, autoimmune condition where antibodies are now produced against what? They are produced against the nicotinic receptors or the acetylcholine receptors, these receptors. Now antibodies are produced against the nicotinic receptors on the muscle. Okay, so now these nicotinic receptors are gone. So now do you think muscle contraction will happen? Muscle contraction is not going to happen. Okay, so that condition is called as a myasthenia gravis. Myasthenia gravis. So what is the problem with the myasthenia gravis? The problem with the myasthenia gravis is antibodies are produced against the nicotinic receptors. What is the problem with Lambert-Eaton syndrome? The problem with the Lambert-Eaton syndrome is antibodies are produced against the voltage gated calcium channels on the neurons. Okay, so that's the difference. This myasthenia gravis is very important for the Indian exams. Mainly this question, not only just Indian exams, all over the world, this question will be asked. 3-4 important questions are there. First of all, how to identify a case on myasthenia gravis is, see in the question what they will tell you is, sir, in the morning, the patient is, okay, initially, the muscle contraction, okay, or I should say like, in a better way, with the more activity, okay, with the more activity, the person is, in the morning it's okay, with the more activity, okay, activity is increasing. With more the activity, the muscle weakness is increasing. For example, in the beginning of the lecture, okay, my muscles are like, I'm having a proper muscle contraction, everything is okay. But with the time, with more work, the more I am walking, the more I am running, the more I am doing the work, the muscle weakness increases and I cannot use my muscles. If you have such kind of a case, they are talking about myasthenia gravis. Okay, so with more muscle activity, the muscle weakness increases, the muscle weakness worsens. This is a classical case of myasthenia gravis. And tell me, myasthenia gravis, it's having a test. There is a diagnostic test. Okay, there is a diagnostic test which is called as a tensilon test, pharmacology. Tensilon test is the test for myasthenia gravis and the drug used is the edrophonium. Okay, so edrophonium is used in the tensilon test and the test done for the myasthenia gravis is tensilon. Tensilon test is a test done for the myasthenia gravis. Completed, sir. Okay, done. Second integration is also completed. First integration is Lambert-Eaton syndrome. The second integration is a myasthenia gravis. What is the test done for the myasthenia gravis? Tensilon test. What is the drug used? It's the hydrophonium. Okay. Antibodies against the voltage gated calcium channels, Lambert-Eaton syndrome. Antibodies against the nicotinic receptors or the acetylcholine receptors is myasthenia gravis. Okay. Next, what you should know, guys. What is this vesicle? I am right now talking about a nerve. Very important. See, this is a nerve. Okay. This is the end part of the nerve where I am showing you this vesicles. This is a vesicle. What is it containing? See, it is containing acetylcholine. Aha, okay. This is the acetylcholine containing vesicle. Okay. In the alpha motor neuron, this is the alpha motor neuron. These are the vesicles, synaptic vesicles, which contain the synaptic vesicles. It contain acetylcholine. Okay. Remember, on this vesicle, there is this blue color protein present. This blue color protein, which I am showing you here, is called as the synaptobrevins. Okay. This is the synaptobrevin. This is the presynaptic membrane. This is the nerve terminus. This is the presynaptic membrane, right? That's the last membrane, presynaptic membrane. Actually, on this presynaptic membrane, there are proteins which are called as the snare proteins. The proteins which are called, very important, don't take them as light. Like, sir, we should have to know. Yes, you have to know them without doubt. See, there are proteins called as snare proteins, which includes syntaxins. Okay. Synaptobrevin, here it is there, synaptobrevin, as well as syntaxins. Syntaxins as well as snap. Syntaxins, snap complex. So now tell me, whenever the action potential is coming, see, whenever, imagine this is the neuron, whenever the action potential is coming to the nerve terminus, this vesicle, which is contained the acetylcholine. Now look here, this vesicle, what it is doing? It is coming and fusing. The synaptobrevin, it is going to fuse with the syntaxin as well as snap. So synaptobrevin is going to fuse with the syntaxins as well as snap. This fusion is very, very important for the exocytosis. Because of this fusion only, the neurotransmitter is going to be released. Okay, because of this fusion, neurotransmitter is released. Okay, sir. Now, why we have to know this? Synaptobrevin, syntaxin. Why unnecessary things? No, important. Because microbiology, this is integration. There is a bacteria called as Clostridium botulinum. Now, this Clostridium botulinum, it is going to produce a toxin called as botulin. Okay, this botulin, how you will get this botulin toxin into you? How you will get this Clostridium botulinum into your bodies? See, if you take the canned foods, preserved foods, canned beans, canned things will be there, no? So if an adult person, okay, imagine I am the person who is taking the canned food. So taking canned foods, or in infants, usually infants will be given the honey. Okay, so if an infant is taking the sporulated honey or contaminated honey with this Clostridium botulinum, if you have any one of them, canned food poisoning or sporulated honey ingestion, now in your body, this Clostridium botulinum is going to produce a toxin called as botulin. This botulin, it will destroy the synaptobrevins. Synaptobrevin, this fellow, the synaptobrevin which is present on the vesicle, this synaptobrevin is now gone. So, whenever the synaptobrevin is destroyed, do you think acetylcholine will be released now? No, the synaptobrevin syntaxin complex cannot happen. So, acetylcholine release cannot happen. Acetylcholine release will decrease. So, whenever there is no acetylcholine, what will happen? The baby or the person is going to have paralysis. No acetylcholine, no muscle contraction. So, the patient is going to have flaccid paralysis. Classically, what they will use is the word descending. Okay, from upper extremities, paralysis will start from the upper extremities and it will go down to the body. So, there is descending flaccid paralysis. Okay, so descending flaccid paralysis is seen in botulism. The toxin is a botulin, damages synaptobrevins. So, synaptobrevin syntaxin complex do not happen. Okay, so acetylcholine release is not going to happen. No acetylcholine, no contraction, leading to descending flaccid paralysis. If you ever hear the word ascending flaccid paralysis, then the answer is Guillain-Barré syndrome. Okay, so in Guillain-Barré syndrome there is ascending flaccid paralysis. I don't want to go into that detail now here. descending flaccid paralysis is seen in botulism. So with this, the integration is also completed. Okay, hope it's clear. All the important points in the muscle physiology are completed. Okay, important points in the muscle physiology for your FMG, whatever you need to know are done. So shall we go to the next thing, the nerve physiology. Okay, what are the important points in the nerve physiology? After that, 50 important MCQs in the respiratory, 50 important MCQs, just question answer. Okay, so we'll take a break of just 5 minutes. 5 minutes break we'll take. Just have a refreshment. After 5 minutes, we will do nerve physiology and important points, important 50 MCQs in respiratory physiology, important 50 MCQs in the CNS also. Okay, take a break of 5 minutes. Break. Begin. It's coming. Okay. Okay, guys, welcome back. Now, after the muscle physiology, now let's discuss about the important points in the nerve physiology. Okay, what you should know before going to the exam. Okay, secret facts mission. Do you have any doubts? So, in nerve physiology, what are the important points which you should know? In the nervous system, what are the different types of cells are there? Neurons are there, as well as some connective tissue cells are there. Like connective tissue cells that are the supporting cells, right? So the supporting cells in the central nervous system are called as the glial cells. Okay, the glial cells are the supporting cells. Now from Thailand, okay, supporting cells. Allowed to visit Thailand one day. Okay, we'll meet once I come there. Okay. Now the glial cells are the supporting cells. Now, what are the different types of glial cells? Okay, the different types of glial cells are astrocytes. Quickly, say astrocytes. What they are helping in? Astrocytes are the cells which are forming the blood-brain barrier. So, the blood-brain barrier is found by the astrocytes. Important point in yesterday's class I have discussed. In astrocytes, there is a type of intermediary filament present. What is the intermediary filament present in astrocytes? The intermediary filament is called as the glial fibrillary acidic protein, GFAP. Glial fibrillary acidic protein, it's an intermediary filament which is present in the astrocytes. So for astrocytomas, in last class also, if you go back to the previous video and see, in astrocytomas, the tumor marker is GFAP. Okay, simple. Astrocytes forming the blood-brain barrier. Inside the astrocytes, what is the intermediary filament which is present? The intermediate filament which is present is the glial fibrillary acidic protein. Next, don't forget, from pathology point of view, if you are having a tumor of astrocytes, then it is called as what? Astrocytomas. In astrocytoma, one pathological finding is seen under the microscope, the astrocytomas. One pathological finding is very important for the exams. Rosenthal fibers, don't forget, okay? Rosenthal fibers are seen in astrocytomas. Don't forget about it. Now, ependymal cells. What are these ependymal cells? 2019 FMGE MCQ. Ependymal cells are the lining cells of the ventricles. Inside our brain, the fluids filled spaces are there, right? With the CSF. The CSF filled spaces are there, which are called as the ventricles. Even in the spinal cord, there is central canal present. Now, this, for example, imagine this is one ventricle. Now, these ventricles, they are lined by cells. These cells are called as ependymal cells. Okay, they are lining the ventricles in the brain and central canal in the spinal cord. Oligodendrocytes. Oligodendrocytes, what are they? They are the myelinating cells. They will cause the myelination around the nerves. Okay, so oligodendrocytes, they will cause myelination where? Oligodendrocytes cause the myelination in the central nervous system. But Schwann cells, they will cause myelination in the peripheral nervous system. Very important, Schwann cells cause myelination in the peripheral nervous system. Oligodendroglial cells cause the myelination in the central nervous system. Central nervous system means brain and spinal cord. Peripheral nervous system means what? Spinal nerves and cranial nerves. 31 pairs of spinal nerves and 12 pairs of cranial nerves, they are a part of peripheral nervous system. In peripheral nervous system, who is doing the myelination? Schwann cells. Okay, and microglial cells. Sir, what are these microglial cells? Microglial cells are nothing but the phagocytic cells. They are nothing but the macrophages in the central nervous system. In the central nervous system, the macrophages and the phagocytic cells are called as the microglial cells. So, basic points. Astrocytes forms the blood-brain barrier. Ependymal cells are the lining cells of the ventricles. Oligodendrocytes are the myelinating cells in the central nervous system. Schwann cells are the myelinating cells in the peripheral nervous system, and microglial cells are the phagocytes. Okay. Never forget, astrocytes contain glial fibrillary acidic protein, which is an intermediary filament. It is a tumor marker. of astrocytomas, and in astrocytomas there are Rosenthal fibers present. Okay, in here itself astrocytomas, under pathology, under microscopy, what you will find out? Rosenthal fibers, RF. Okay, Rosenthal fibers are present. Next, types of neurons. Types of neurons. See, there are unipolar neurons, pseudo-unipolar neurons, bipolar neurons, multipolar neurons. 4 different types of neurons are there. For your exam, 2 types of neurons are very important. Pseudo-unipolar neuron. Okay, pseudo-unipolar neuron. See, the pseudo-unipolar neurons present where? They are present where? They are present in the dorsal root ganglion. Okay, I will later show you what exactly is this, the dorsal root ganglion. So in the DRG, dorsal root ganglion, which type of neurons are present? Pseudo-unipolar neurons are present. Okay. Then bipolar neurons are present where? Bipolar neurons are present in the retina as well as the olfactory epithelium. Okay. In the retina, in our eye retina, as well as the olfactory epithelium, bipolar neurons are present. So pseudo-unipolar neurons are present in the dorsal root ganglion. Bipolar neurons are present in the retinal olfactory epithelium as well as the retina. Next, after this, very important, the heart of the nerve physiology is the action potentials. Okay, action potential in a neuron. Before that, let me tell you. See, this is the neuron. The basic neuron is a multipolar neuron. Okay, basic multipolar neuron. Now tell me, what is this area? This is called as a cell body, sir. What is this part? See, this is a part of cell body, the tubular area. This is a part of cell body which is now going to form the axon. This area is called as the axon hillock. Okay, this area is called as the axon hillock. And the first part of the axon is called as the initial segment. Okay, axon hillock and initial segment. These are the important points which I want you to know. Okay, next, sir. In this neuron, have you identified this, like, myelinated areas? These are the myelinated areas. Okay, Schwann cell is myelinating these areas. In between these myelinated areas, there are these unmyelinated areas present. These are called as nodes of Ranvier. Okay, which later I have written everything. Just I am explaining. These are the nodes of Ranvier. Okay, nodes of Ranvier. Now, look, MCQs. What are Nissl bodies? Okay, what are these Nissl bodies? Where are they present? See, these Nissl bodies are nothing but the rough endoplasmic reticulum. In the neuron, okay, lots and lots of neurotransmitters, proteins are going to be synthesized, right? See, these endoplasmic reticulum, which is present in the cell body, these are nothing but the Nissl bodies. Okay, so what are these Nissl bodies? They are nothing but the rough endoplasmic reticulum. You know the axon hillock. What is the axon hillock? Axon hillock is the site of action potential generation. Later I will tell you in which neurons, whether in sensory neurons or motor neurons, later I will tell you. But just remember, what is axon hillock? Axon hillock is a part of cell body. It's not a part of axon, it's parts of cell body. Okay, it's a part of the cell body of the neuron. And actually that's the site of action potential generation. And what are the nodes of Ranvier? Let me go a little fast. Nodes of Ranvier. Nodes of Ranvier are the unmyelinated areas. See, these nodes of Ranvier, these are the unmyelinated areas. In these nodes of Ranvier, we have lots and lots of sodium channels. Okay, so sodium channels, voltage gated sodium channels are present, where the maximum number of sodium channels are present in nodes of Ranvier. Okay, next topic. Let's enter into the topic. That's the action potential generation. Normally, imagine this is the neuron. It is sleeping. Okay, it is sleeping. Now, how the action potential is going to be generated? What are the phases of the action potential? First of all, how many types of neurons are there? See, according to the function, there are 2 types, sensory neurons as well as the motor neurons. In a motor neuron, where the action potential is going to be originating. Action potential, the first depolarization, action potential originates from the axon of hillock as well as the initial segment. Both from these areas, from the junction of the axon hillock and the initial segment, from this area action potential arises in the motor neurons. But if I am talking about the sensory neurons, where action potential is originated, activation, where it is originated, it's from the first node of Ranvier, first space will be there, right? From the first node of Ranvier, the action potential is going to be originated. So this is a little difference. Action potential origin in a motor neuron is from axon hillock and the initial segment. Action potential generation in a sensory neuron, it is coming from the first node of Ranvier. Done. Now, see, this is a neuron. Okay, this is a neuron. Doesn't matter whether it's a alpha motor neuron or it's a sensory neuron. Motor neuron or sensory neuron doesn't matter. It is sleeping. It is resting. It is not activating. It's sleeping. When it is sleeping, what is the resting membrane potential? Okay, inside this nerve, what is the voltage? First MCQ, the resting membrane potential of a neuron is minus 70 millivolts. Many times question was asked. Okay, so the same was shown over here, minus 70. It is sleeping. Okay, whenever an impulse is coming from the surrounding neuron, or whenever you give the impulse, what happens is this resting membrane potential from minus 70, excellent Yashank, you are true. From minus 70, see, it is reaching the threshold. For example, you give a little stimulus. Now, if this stimulus is powerful enough, for example, you are giving a light stimulus, that is not enough. If you are giving enough stimulus, now this is a neuron, okay? The resting membrane potential, now where it is going? From minus 70, it is reaching minus 55, okay? It is reaching minus 55. Now, what is this 55? This 55 is considered as the threshold potential. What first happens? Now it is sleeping. Whenever stimulus is coming, if the stimulus is bringing the resting membrane potential to minus 55. Minus 55 is known as threshold potential. From minus 70, minus 55 is getting attained. Okay. Now, do you know what happens? Once the threshold potential, once it is attained, action potential will start. Depolarization will start. 100% depolarization is inevitable. Once the threshold potential is attained, immediately, do you know what happens? On this neuron, suddenly the voltage gated sodium channels will open. This voltage gated sodium channels will cause influx of the sodium into the cell. Will cause influx of the sodium into the neurons. Sodium goes into the neurons. Positive ions are going into the neurons. So neuron is activated. So that's why, see, there is a depolarization. From minus 55, from negativity, the neuron potential is becoming positivity. Excellent. Ashank, you are true. From minus 55, see, it is going towards the positivity. Now tell me, what is this phase called as? This phase is called as a depolarization. Okay. Now tell me, depolarization is because of what? Depolarization is because of influx of sodium. So it's a depolarization in a nerve is dependent on the sodium influx. During depolarization, sodium influx happens. Yeah. After activation, okay, nerve is activated. Now, what happens? Again, it have to go back to its original resting membrane potential. Okay. Depolarization happened. The depolarization will spread. Now, what should happen? Again, it have to come back. No. So now repolarization should happen. The nerve, now what happens is, on the nerve, potassium channels will open. Okay, potassium channels will open on this nerve membrane. Potassium channels will open and the potassium will start to go out of the cell. Potassium is positive ion. It is going out of the cell. When positive ions, potassium is going out of the cell, repolarization means, see, the membrane potential is now again coming back. Okay. And not only it will just come back to its resting membrane potential, sometimes it can even go below that resting membrane potential. So first you are having repolarization because of the efflux of potassium. The efflux of potassium will cause the repolarization. This repolarization just doesn't stop with the resting membrane potential. Sometimes it can even go into the hyperpolarization, means inactivation, complete inactivation. See, the cell is going into full negativity, minus 100 or minus 90, means going down. This is called as hyperpolarization and it is also because of potassium efflux. Okay, potassium efflux, not only that MCQ, chloride influx. Chloride ions, negative ions, chloride ions are coming in. Chloride ions are coming into the neuron, making it hyperpolarized. So now tell me guys, first resting membrane potential minus 70, threshold potential minus 55. Once threshold potential is attained, all or none phenomena, 100% depolarization will happen. Sodium channels are opened. Sodium comes into the cell. Voltage gated sodium channels are open. Sodium comes into the neurons, causing the depolarization of the membrane, depolarization of the neurons. Now, after depolarization, depolarization is followed by the repolarization. Repolarization is due to potassium efflux. After repolarization, there is a small period of hyperpolarization, which is also due to potassium efflux as well as chloride influx. Hyperpolarization means inactivation, complete inactivation. Okay, so these are the points I want you to know. See here, phase 1. Now you should tell me what is the phase 1 from 72 minus 55. This is depolarization. Phase 2. Sorry, not depolarization. Sorry, little confusion. No. So what is the phase 1? Phase 1 is attainment. Okay, first stimulus. Phase 1 is minus 72 minus 55 means threshold potential is reaching. Okay, first threshold potential is reaching. Next what? Once the threshold potential is reached, next phase 2. Phase 2 is depolarization. After depolarization, what do we have? Repolarization because of potassium efflux. After that, what happens? Hyperpolarization because of potassium efflux as well as chloride influx. Now, after hyperpolarization, see, after hyperpolarization, again the neuron is coming back to its resting membrane potential. That's the phase 5. That's the phase 5. Okay, so these are the 5 phases which I want you to know. First, threshold potential, depolarization, repolarization, hyperpolarization, coming back to resting membrane potential. These are the points which I want you to know. Now, after this, many times in your FMG exam, this question has been asked. Like, no, general question. What is absolute refractory period as well as relative refractory period? Okay, absolute refractory period as well as the relative refractory period. Simple. Absolute refractory period means, see, look here. This is the threshold, no? This is the point of threshold. Here is the this is the resting membrane potential. This is the point of firing. Okay, right away from the point of firing. See now, this is, this is the depolarization. After that, what happens? Repolarization. This is the area. Okay, 1/3. Okay, that's the 1/3 of the repolarization. Now, what's the point what I'm trying to put into your mind is, say, in this time, okay, during this time, during this period, for example, here you are giving the one more stimulation during this time or during this time here or at this level, you are giving the stimulation to the neuron again. Okay, now imagine this is the neuron. Now it is undergoing depolarization and now it's slowly repolarizing. Again, if you stimulate this neuron powerfully, so much powerfully, do you think that it will generate one more action potential now? Never. So during this period, which I have highlighted, during this area, you give how hard the stimulus is, doesn't matter. No new action potential generation. So point is, absolute refractory period, during this absolute refractory period, initiation of new action potential is not possible at all. It doesn't matter how strong the stimulus is. Doesn't matter how strong the stimulus is, no action potential is going to be generated. No new action potential. Why? The reason what they will ask is the why. Why? It is due to inactivation of voltage gated sodium channels. During this absolute refractory period, during that period, the voltage gated calcium channels, not calcium channels, correction, voltage gated sodium channels. These voltage gated sodium channels are closed, they are inactivated. As they are inactivated, there is no chance of new action potential. Okay, so absolute refractory period, no action potential due to inactivation of the voltage gated sodium channels. Done, sir. Now let's talk about the relative refractory period. Then what is relative refractory period? Look here. Same from this area. Okay, still repolarization as well as hyperpolarization and coming back to resting membrane potential. Okay, this during this period, if you give one more stimulus, with the normal stimulus, new action potential is not going to be generated. With the powerful stimulus, if you give powerful stimulus, then a new action potential will be generated by the neuron. Okay, so this period is the relative refractory period. Okay, even here say this area is the relative refractory period. From where to where? This area. Okay, relative refractory period. During the relative refractory period, initiation of the new action potential is possible. But what you need to do, not just the normal stimulus, you need to give the powerful stimulus. You need to give a higher stimulus, MCQ. Okay, that higher stimulus can actually open the sodium channels. Okay, so anyway, by that time sodium channels will be open. That mechanism is little different. I don't want to go into that detail now. Absolute refractory period, relative refractory period. Absolute refractory period, no action potential. Relative refractory period, yes, action potential will be produced, but you need to give the higher stimulus. In absolute refractory period, why there is no action potential? Because the sodium channels are closed. Okay, voltage gated sodium channels are inactivated. Now, see, 99% of the time, if I am the examiner or whoever the examiner, they will give question from this area only. Whatever, like, the rapid revision course or whatever, like, the coaching institute you go. Without this, there is no nerve physiology. 100% question will come from here only, this area only. This area is the classification of nerve fibers. The classification of the nerve fibers. The nerve fibers are classified into different types. Okay, based on what, sir? For example, you look here, there is A alpha type, A beta, A gamma, A delta. Okay, B type of fibers, C type of fibers, type 1A fibers, 1B, 2, 3, 4, different types of nerve fibers are there. These fibers are classified into different types based on what? Based on myelination. Okay, so classification of nerve fibers is based on the myelination. So you should understand here, think logically and tell me, for example, this is a neuron. Okay, if it is having more myelination, if this nerve fiber, if it's having more myelination, is it good or bad? It's good. Because more the myelination, more insulation is there. So with very fast speed, the conduction will happen. Okay, the conduction of the impulses will happen with a very fast speed. So more the myelination, tell me what is the importance of this myelination? More the myelination, more the speed of the conduction along the neurons. Okay, and one more thing is the diameter. Okay, more the diameter of the neurons. If imagine this is a neuron, the cross section, the diameter, more the diameter, again more speed of conduction. So the speed of conduction is determined by two parameters. What are the two parameters that determine the speed of conduction? One is the myelination and other is the diameter of the neurons, MCQ. So based on these two things only, mainly based on the myelination, the neurons are classified into different types. First classification is called as the Erlanger-Grassy classification. Okay, so what is this Erlanger-Grassy classification? According to the scientists, they classified, imagine these are the friends. Okay, what they have classified is they are saying different types of neurons. Okay, they are seeing the different types of nerve fibers. Now one nerve fiber is highly myelinated. Other type of nerve fiber is having little myelination. The other thing is having no myelination. So based on the myelination, they have categorized the nerve fibers into A, B and C. So when you are moving from A, look, when you are moving from A to C, what happens to the myelination? See, myelination decreases. So A fibers are highly myelinated, C fibers are unmyelinated. Okay, so that's the point which I want you to know. So now tell me, when you are moving from A to C, what happens with the myelination? A is having heavy myelination, B is having little myelination, C is having no myelination. Done. Okay. So according to Erlanger and Grassy, there are A fibers, B fibers as well as C fibers. Now there is one more classification, one more fellow, Hunt. There is one more scientist. He is also saying these nerve fibers. He don't want to call them ABC. He doesn't like ABCs. Okay. He's saying he's a mathematician. Imagine he's in love with numbers. Okay. Right. He's not a mathematician anyway. He loves the numbers and he's saying this is 1, 2 and 3. So it's the same thing, same nerves only. But according to one fellow, it is ABC. One classification is saying A fiber, B fiber, C fiber. The other guy is saying type 1 fiber, type 2 fiber, type 3 fiber and type 4 fiber. Okay. So here, look here, according to Erlanger-Grassy classification, okay, we have A fibers. These A fibers are further divided into A alpha, A beta, A gamma, A delta. B fibers as well as C fibers. According to the numerical system, it is divided into 1, 2, 3, 4. Okay, 1, 2, and 3 and 4. What are the important points which you need to know? Okay, super important points, sir. See, A fibers already I have taught you. Okay, they are having more the diameter, they are having more myelination. Okay, they are having more myelination. These are the large neurons, large myelinated neurons. They are having more diameter. Conduction velocity is super high. Okay, why? Because more myelination. So let's look at the important points. A alpha fiber, yes, it is highly myelinated. When you are moving from A to C, myelination decreases. So A is highly myelinated. That too, A alpha is the highly myelinated than A beta or A gamma. So highly myelinated. They are having highest diameter, true, and they are the thickest and fastest. Highest conduction velocity is going to be seen. MCQ. Okay, and what are these A fibers? We know no alpha motor neurons causing the muscle contraction. These alpha motor neurons are what? A alpha. That's the thing. A alpha. They are the motor neurons which are helping in the muscle contraction. Okay. In the spinal cord, A alpha motor neurons, they are originating and they are coming and innervating the skeletal muscles. So A alpha are the motor neurons. So the same thing, look here. A alpha are the somatic motor, which means they innervate the skeletal muscles. Innervate the skeletal muscles. And not only that, see, this A alpha, it is also doing one more function, proprioception. Proprioception is a sense, right? It's not a motor activity. Proprioception is a sense of the joints, sense about the body parts in the three-dimensional space. So proprioception is a sensory thing. So now tell me, this A alpha, is it a motor neuron or is it a mixed neuron? A alpha is sensory as well as motor. The alpha motor neuron as well as it is also doing which functions? Proprioceptive function. Very, very important. Put 10 star marks. The proprioceptive function is done by A alpha. Okay, A alpha. Proprioceptive fibers. From where this proprioception is coming? The proprioception is coming from the muscle spindles as well as the Golgi tendon organs. From the muscle spindles and from the Golgi tendon, organs, its A alpha fibers are taking the information, proprioceptive information into the central nervous system. Okay, so now please tell me important points. A alpha, they are the large, myelinated, thickest fibers with the highest conduction velocity. A alpha are both the sensory as well as motor. They are the alpha motor neurons. What is the sensory function? Proprioception from the muscle spindles, from the Golgi tendon organs. From the muscle spindles and the Golgi tendon organs, the information, that's a proprioceptive information, is going to the central nervous system via the A alpha. Okay, so done, sir. Next, A beta. So A beta, they are the pure sensory. Okay, they are the sensory fibers. What they are doing? They are taking which type of information? They are taking the fine touch. They are taking the fine touch information. Fine touch information is carried by A beta fibers, pure sensory. And A gamma, alpha, beta completed, now gamma. A gamma fibers. Gamma, the gamma motor neurons. Just like alpha motor neuron, this is the gamma motor neuron. So gamma motor neurons, where they are going? Gamma motor neurons are going to muscle spindle. So muscle spindles are having, yes, sensory supply is there. Now if you see here, this muscle spindle, it is having sensory supply from A alpha. These muscle spindles are also having motor supply. Motor supply is coming from where? A gamma fibers. So super important MCQ. If I am the examiner, definitely I will give you this question. Muscle spindles are innervated by the gamma motor neurons. Gamma motor is nothing but A gamma. Okay, A gamma fiber is nothing but the gamma motor neurons going to the muscle spindles. So now just recap. A alpha, both sensory as well as motor. A alpha, alpha motor neurons. A alpha, proprioception. Highest conduction velocity, thickest and largest, highly myelinated. Next, A beta. A beta is fine touch. A gamma. A gamma is a gamma motor neuron for the muscle spindle. It's a pure motor. It's a motor neuron. It's a pure motor. Okay. Now, A delta. What do you need to know regarding the A delta fibers? See, these A delta fibers, they are the ones which are going to cause the paresthesias. Okay. So, this A delta fibers, they are the ones which are responsible. See, damage to this A delta fibers. Okay, whenever this A delta fiber, if it is damaged, that's going to cause the tickling sensation, like numbness. So those are the paresthesias, like shock-like sensations. See, these are the paresthesias MCQ. Paresthesias are due to damage to which fibers? Damage to A delta fibers. Okay, damage to A delta fibers. And these A delta fibers are the ones which also carry cold sensation, cold temperature, as well as the fast pain. Many times this question has been asked. Okay, many times this question has been asked as the fast pain, not a dull pain, dull and diffuse pain. No, fastest speed of conduction. Okay, for example, someone comes and prick you. Fastest speed of conduction is with the A delta. A delta fibers are damaged, leading to paresthesias. A delta fibers are the ones which carries the cold temperature. Fine touch is carried by A beta. Gamma motor neurons to the muscle spindles, A gamma fibers. Okay, so A is completed. A alpha, A beta, A gamma, A delta. Okay, so what we have completed? This one. Now tell me, cold sensations are carried by A delta. Cold sensations. Fast pain, sharp pain, fast pain, epicratic pain, sharp with a pinprick is going to be A delta. Now B. What are these B fibers? B fibers. Where they are present in our body, where they are present. In your pharmacology, autonomic nervous system, you have studied, right? Okay. See, B also myelinated only, but not heavily myelinated. B also myelinated. Okay. But A is highly myelinated. A alpha is highly myelinated. Now, this B fellow, this B fiber, these are the preganglionic fibers. Okay, these are the preganglionic fibers. In autonomic nervous system, you have studied preganglionic fibers, ganglia, sympathetic ganglia will be there, postganglionic fibers will be there. Preganglionic, ganglionic, postganglionic. Okay, preganglionic fibers, there is sympathetic ganglia there, postganglionic fibers. So, all the preganglionic fibers are A beta, sorry, not A beta, it's a B fibers. Okay, not A beta, sorry, it's a B fibers. B fibers are the preganglionic. Answer. And C fibers. Many times this question has been asked. C fibers. You are going from A, B, and C. You are coming to the C. No myelination. They are small fibers, no big diameter. So do you think conduction velocity is fast? No, slow conduction velocity. So what they will what type of pain they will carry? Slow pain, dull and diffuse pain. So the C fibers, they are unmyelinated. Okay, they will carry slow pain. Super important MCQ. And where they are present, they are the postganglionic sympathetic fibers. Okay, postganglionic sympathetic fibers. Okay, so C fibers are unmyelinated. Postganglionic sympathetic fibers, they carry the slow pain, dull or diffuse pain, visceral pain, protopathic pain, slow pain. Okay, now they carry which type of temperature? Hot temperatures. Hot temperature. So cold temperature is carried by A delta. A delta cold temperature. C fiber hot temperature or warm temperature. Okay, see, this C fiber already I have written. C fiber, yes, they are postganglionic fibers. They carry slow pain and they carry hot temperature. Cold temperature by delta, hot temperature by. So with this, if you know this, 100% one question will come. Okay, based on the classification of fibers, one question will come. Simple. Paresthesias, tell me. Paresthesias. Are you any doubt? Paresthesias. Guys, do you have any doubt? If you are like, feeling that I'm going little slow, you can say, sir, you are getting it, you can go fast. Or if you feel like, sir, you are going fast, you can say, sir, go little slow. Okay, I'm a student-friendly teacher. I will act according to you. So what I'm asking, proprioception, paresthesias. The paresthesias are due to damage to A delta. Okay, now after this, a very much controversial area. Yes, Shashank, you are true. Say delta. A very much controversial area which we are going to discuss is if you use local anesthesia from anesthesia, if you inject local anesthesia, okay, the local anesthetic agents like lidocaine or xylocaine, okay, these local anesthetics will knock out which fiber first. The local anesthetics, just follow this. Don't go into any contradictions, in simple, just follow this. Lifelong, just remember this, okay? Local anesthetics will first knock out A gamma fibers. So A gamma fibers are the most sensitive, which means they'll be inhibited. When you inject local anesthetics, they will go into sleep. Okay, so A, gamma are the most sensitive to the local anesthetics, followed by B, followed by C. Okay, next, whenever there is a pressure, okay, pressure will knock out. So whenever there is a pressure, that pressure will knock out which type of nerve fibers? A alpha. Okay, first A fibers will be affected. Even in the A fibers, A alpha. Okay, so pressure will knock out A alpha, followed by B, followed by C. Okay, next hypoxia. Which fibers are more sensitive to hypoxia? Whenever there is hypoxia, it's gone. If there is any persistent hypoxia, this fiber will be damaged. So hypoxia sensitive. I used to remember like hypoxia, is it a good thing? Definitely hypoxia is not good. So we'll say hypoxia. Okay, let me take my step back. Hypoxia back. So BAC. I used to remember something like that. Okay. So which fibers are most sensitive to hypoxia? B fibers. Remember B. What B fibers are doing? B fibers, they are the preganglionic. Don't forget. B fibers, they are the preganglionic sympathetic fibers. They are myelinated or preganglionic sympathetic fibers. Now B, A, C. Now tell me local anesthetics. First A gamma. Next pressure, with pressure, A alpha fibers are going to be damaged. And hypoxia, BAC. BAC. Okay. Never ever forget. Alpha motor neurons are A alpha. Gamma motor neurons are A gamma. Paresthesias are A delta. Okay, paresthesias are A delta. Cold temperature, A delta. Warm temperature, C fibers. Fast pain, A delta. Slow pain, C fibers. Unmyelinated, C fibers. Okay. Now, with this, important topics which you should know in the nerve physiology for the exam. Okay, if you know this much, it's good. Okay, important points in the nerve physiology is also done. Now, let's do the respiratory physiology. Okay, now the respiratory physiology we should complete just in maximum 15-20 minutes. In the next 15-20 minutes, we should be able to complete the respiratory physiology. Okay, so shall we do the respiratory physiology, guys? Yashank, Shiksha, Yashank, Bill, Jenny, shall we go forward? Secret facts, shall we go forward? Is it okay? Okay, nice. So, respiratory physiology, you just try to answer yourself. Okay, see, lung airway generations. How many lung airway generations are there? See, the respiratory tract is divided into many generations, small segments, and these segments are called as the generations. Okay, just to make our life more complicated, some guy have divided this into many segments and they call it as generations. And how many generations are there? 23 generations are there. Starting from 0. If you consider 0, there will be 24 generations. Okay, so there are 23 generations are there. Okay, what is the generation 0? See, the generation 0, what is that? It's a trachea. So generation 0 is trachea. Okay, sir. So conducting zone, the entire respiratory tract, it is divided into, okay, let me show you here itself. The entire respiratory tract, the respiratory tree, it is divided into two zones, the conducting zone and the respiratory zone. In the conducting zone, no gaseous exchange. No gaseous exchange happens in the conducting zone. In the respiratory zone, this down area, see, this is the respiratory zone. Conduction happens, exchange of gases. Exchange. Okay. Gases exchange present. Here, no gas exchange. Okay. So conducting zone as well as the respiratory zone. Now tell me, what is the last part of the conducting zone? Conducting zone ends with the terminal bronchioles, MCQ. Okay, that's the point which I want you to know. Conducting zone ends with terminal bronchioles. Okay, yes. Yes, Samantha. Friendly doc, yes. So terminal bronchioles, they are the last part of the conducting zone. Can you tell me maximum airflow resistance in the respiratory tract? Where will the maximum airflow resistance is seen? It's the maximum airflow resistance is not is shown by the bronchi. Okay, the medium sized bronchi. Now let me directly show here itself. Okay, now the maximum airflow resistance is shown by the medium-sized bronchi. Okay, not the bronchi, like which are like lobar and segmental bronchi. Okay, so the lobar and segmental bronchi. The questions are here. Answers will also are already written over there. There is no problem for you. You can get the entire PDF. So tell me, in which part of the respiratory tree maximum airflow resistance is going to be seen? The maximum airflow resistance is seen not in the bronchioles, not in the trachea, not in the respiratory zone. It's in the bronchi or bronchus. Which bronchus? Lobar and segmental bronchus show maximum resistance. Okay, lobar and segmental bronchus. Done, sir. Conducting zone is lined by general basic MCQs. The conducting zone, the respiratory tree is lined by pseudo-stratified ciliated columnar epithelium. Pseudo-stratified ciliated columnar epithelium. Check yourself. Answer was given anyway. So pseudo-stratified ciliated columnar epithelium is present in the conducting zone. But which epithelium is present in the respiratory zone? In the respiratory zone, the down area where gases exchange happens. What is epithelium? Simple squamous epithelium. Okay. So conducting zone. Okay. Now here itself, let me write the respiratory zone lined by simple squamous epithelium. So simple squamous epithelium is the epithelium of the respiratory zone. Next, there is a syndrome. Okay, there is a pulmonary pathology which is called as the Cartagena syndrome. What is the defect in Cartagena syndrome? What is the problem? Can you tell me? Come on, friendly doc. Bill. Bill, yeah, we haven't discussed about the smooth muscle contraction, mainly because, like, in our exams, like, we don't have enough time to discuss about everything, right? Mainly, I'm talking about the most important areas. Okay. So, after this, we are going to plan physiology classes, like, total system. Okay, total system wise physiology classes we are planning. Means total system wise, every system. There we will cover entire things. And system wise pathology also we are planning. There we will discuss in detail. Okay. Now, so Cartagena syndrome, what is the defect? In the Cartagena syndrome, the dynein arms, okay, dynein arms is defective. Imagine this is cilia. Okay, inside the cilia there is a protein called as the dynein. Okay, dynein. This dynein is defective. When the dynein is defective, do you think the cilia will beat? No, the cilia is not going to beat. When the cilia is not beating in the respiratory tract, mucus plugging will happen. Mucus will start to accumulate. That will cause respiratory problems. Okay, that's the Cartagena syndrome. So now look here. In Cartagena syndrome, see, where is the defect? Defect is in the dynein arms. So a triad of symptoms are going to be seen. So what are the triad of symptoms? The triad of symptoms in the body. The cilia are not beating. Okay, don't see all the MCQs. The cilia are not beating. Because the cilia are not beating in the respiratory tract, the patient will have respiratory tract infection leading to bronchiectasis. Okay, necrotizing inflammation of the bronchi leading to the permanent dilation of the bronchi. Bronchiectasis is going to be seen. Mucus plugging followed by infection, followed by inflammation, necrotizing inflammation leading to bronchiectasis. Okay, so first triad of symptom which I want you to know, the first triad of symptom is the bronchiectasis. What else? Normally, cilia are also helping in the proper positioning of the organs. Okay, cilia are very much important for the proper position of the organs. Because the cilia are not beating properly from birth itself, the heart which was supposed to be placed towards the left side, now the heart will be placed, the apex will be facing towards the right side. Normally, during embryogenesis, it's the beating of the cilia will actually help in the positioning of the heart more towards the left side. Cilia are not beating, heart positioning is not happening properly, so heart will be towards the right side. That is a situs inversus. Okay, situs inversus or dextrocardia means right sided placement of the heart. Okay, so that's the problem. So now look here. Now in Cartagena syndrome, there is sinusitis, inflammation because of the mucus accumulation. Cilia in the mucus, cilia in the sinuses are not beating properly. So mucus drainage is not happening properly. Mucus plugging will happen that will lead to infection in the sinuses. That's the sinusitis. Sinusitis. In the respiratory system, there will be bronchiectasis as well as situs inversus. This is the triad. Okay, infertility is not in the triad, but the triad is sinusitis, bronchiectasis as well as situs inversus. Infertility will be there because the cilia, the flagella of the sperms do not beat properly. Okay, that's a problem. Next, let's look for the stem cells in the airway. In the airway, there are three types of stem cells present. One is the type 2 pneumocytes. So the type 2 pneumocytes, what is the importance? They will produce a surfactant. Clara cell, there is a cell called as Clara cell, and there is one more cell called as a basal cell. See, these three cells are the stem cells in the airway. So stem cells in the airway are the type 2 pneumocytes which produces the surfactant, Clara cells as well as the basal cells. Next, what is the most potent bronchoconstrictor? During asthma, bronchoconstriction will happen, right? What is the most potent bronchoconstrictor? Is it histamine? Is it prostaglandin? Is it a leukotriene? What? So the most potent bronchoconstrictor is leukotrienes. Okay, leukotriene, especially leukotrienes, LTP4, are the most potent bronchoconstrictors. Done. In the respiratory tract, in the respiratory tree, from trachea, bronchi, bronchioles, this entire thing is there, right? Which part have the maximum smooth muscles? The maximum smooth muscles are present around trachea, bronchi, bronchioles, where? Terminal bronchioles. The maximum smooth muscles are present around the terminal bronchioles. Okay, terminal bronchioles. Just think, in the cardiovascular system, maximum smooth muscles are present around what? Aorta, arteries, arterioles. Remember, maximum amount of smooth muscles are present around the arterioles. That's why arterioles are called as resistance blood vessels. Here in the respiratory tract, the maximum amount of smooth muscles are present around the terminal bronchioles. Okay, done. Surfactant is produced by, you already know, surfactant is produced by type 2 pneumocytes. And what is the function of the surfactant? What is the function of the surfactant? Makes you beautiful? No. Surfactant decreases the surface tension in your alveoli, prevents the collapse of the lungs. MCQ. So surfactant, it is produced by type 2 pneumocytes, type 2 alveolar cells, type 2 pneumocytes. That was anyway given over here. Say surfactant is produced by the type 2 pneumocytes and their function is to decrease the surface tension, prevents the pulmonary edema as well as prevents the collapse, alveolar collapse. Next, the surfactant is made up of what? Surfactant is made up of lipids, sir. What is the major lipid in the surfactant? MCQ. What is the major lipid in the surfactant? There is a major lipid, there is a minor lipid. Major lipid is called as DPPC, dipalmityl phosphatidylcholine. Okay, dipalmityl phosphatidylcholine, also called as lecithin. So, but dipalmityl phosphatidylcholine or lecithin is a major lipid in the surfactant. Can you tell me what is the minor lipid? Shashank, can you tell me? Jenny, Shashank, Siksha. Can you tell me, guys, what is the minor lipid? It is start with the letter S. Sphingomyelin. Okay, sphingomyelin is a minor lipid. Okay, don't forget, major lipid is DPPC or lecithin. So, what is the indicator of fetal lung maturity? How can we know that the fetal lungs are matured or not? Okay, the period of gestation is maybe 33 weeks or 34 weeks. Now, you want to know whether the fetal lungs are matured or not. Okay, this lady is going into the preterm labor. You are little worried whether the fetal lungs are matured or not. If you want to know whether the fetal lungs are matured or not, then you can go for lecithin sphingomyelin ratio. The ratio of lecithin to sphingomyelin. If the lecithin sphingomyelin ratio, if it is greater than 2, it indicates fetal lung maturity. Done. So first group of MCQs completed. These are the direct MCQs. Weeble Sageway generations 23. Generation number 0 is trachea. Conducting zone ends with the terminal bronchioles. Maximum resistance to the airflow is seen in the lobar and segmental bronchus, which are the medium-sized bronchus. And the conducting zone is lined by pseudostratified ciliated columnar epithelium. But the respiratory zone is lined by the simple squamous epithelium. In Cartagena syndrome, there is a defect in the dynein. Because of that, the patient is going to have a triad of symptoms. What are they? Bronchiectasis, sinusitis, as well as situs inversus. That's the dextrocardia, right side placement of the heart. Even the males or females are going to be also infertile. Okay, because the flagella of the sperm is not beating properly, and the cilia inside the fallopian tubes also don't beat properly. That will cause infertility. Most potent bronchoconstrictor is the leukotrienes. Maximum amount of smooth muscles in the respiratory tract is around the terminal bronchioles. Other things, you know it. Okay. Now, pacemaker of the respiration. Can you tell me what is the pacemaker of the respiration? Come on, dudes. Come on, doctors. What is the pacemaker of the respiration? Every student knows that the pacemaker of the heart is, sir. SA node. SA node is the pacemaker of the heart. What is the pacemaker of the GIT? Interstitial cell of Kajal. We have already discussed there. The migratory motor complex. Okay, the basal electrical rhythms. Okay, the spike potentials we have discussed in the previous videos. Okay, go and check there. What is the pacemaker of the respiration? The pacemaker of the respiration is pre-Bott-Zinger complex. Okay, pre-Bott-Zinger complex. Now, if you look over here, there are multiple centers which are regulating the respiratory activity. Look here, there is something called as a pre-Bott-Zinger complex. Actually, it is present in the medulla. Okay, so the pre-Bott-Zinger complex which is present in the medulla is considered as a pacemaker of the respiration. There is a gene called as CFTR gene. If the CFTR gene is mutated, gone. Yeah. Okay, CFTR gene, gone. Whenever the CFTR gene is mutated, it's going to cause, okay, it's going to cause a condition which is called as cystic fibrosis. Why the cystic fibrosis? CFTR gene is mutated, so the chloride channels are going to be defective. Because these chloride channels are defective, I'm just briefing it up. The chloride channels are not functional. So the secretions which are happening in the entire body, not only in the respiratory tract, everywhere in the body, the secretions are going to be thicker. Okay, the secretions are going to be thick secretions that will block the respiratory tract, leading to bronchiectasis, pulmonary infections. Okay, that's the problem. So CFTR gene mutation is the one which causes a condition called as a cystic fibrosis. In this cystic fibrosis, the chloride channels are going to be defective. Because of this, the secretions are going to be thick secretions. The thick secretions will block the respiratory tract, leading to the pulmonary infections, mucus plugging. Next, the disease, which I want you to know is, see, if there is a deficiency of alpha-1 antitrypsin. Okay, there is this enzyme called as alpha-1 antitrypsin. When this alpha-1 antitrypsin, excellent, Mir Ahmad, yes, cystic fibrosis. If alpha-1, now, Mir, could you answer this? If alpha-1 antitrypsin, if it is deficient, it will cause which pulmonary condition? Alpha-1 antitrypsin deficiency is going to cause chronic obstructive pulmonary disease, asthma, bronchitis, bronchiectasis. No, it is going to cause, yes, a COPD, but what is that? Example, it is emphysema. It's going to cause emphysema, sir. Which type of emphysema? If imagine I am the person who is having alpha-1 antitrypsin deficiency. If I am the person who is having alpha-1 antitrypsin deficiency, yes, I will suffer with emphysema, no doubt. Okay, I will suffer with emphysema. But which type of emphysema? Pan-acinar emphysema. Very, very important. Don't forget. Pan-acinar emphysema. In smokers also there will be emphysema. In smoker fellows, okay, they will also develop emphysema. But which type of emphysema? Just remember, centri-acinar emphysema. This was the question asked in the recent FMGE exam. So smokers are going to develop emphysema. True. But which type? Centri-acinar. Alpha-1 antitrypsin deficiency. Okay, alpha-1, yes, mountain life, you are true. Alpha-1 antitrypsin deficiency is going to cause emphysema. But which type of emphysema? Pan-acinar emphysema. And what is the pre-Bott-Zinger complex? The pre-Bott-Zinger complex is the pacemaker of the respiration. Done. Okay. Now, after this, let's continue. Surfactant is stored where? You know, surfactant is produced by the type 2 pneumocytes. The type 2 pneumocytes or the type 2 alveolar cells produce the surfactant. Surfactant decreases the surface tension, prevents the collapse of the alveolus. Everything good. Surfactant, it is stored where? In which vesicles? Lamellar bodies. Lamellar bodies. That's the MCQ which was asked. See, imagine this is a type 2 pneumocyte. Okay, this is type 2 pneumocyte. Inside this type 2 pneumocytes, there are these vesicles called as the lamellar bodies. Inside this lamellar bodies, guys, see, inside this lamellar bodies, surfactant is going to be stored. Okay, very important. Now, what is this hyaline membrane disease, sir? Why hyaline membrane disease? This hyaline membrane disease is due to deficiency of surfactant. So deficiency of surfactant is going to cause the hyaline membrane disease. Done. Okay. Now trachea. See, trachea is lined by which type of epithelium? Very simple. See, trachea is a part of conducting zone. It's a part of conducting zone. No. So it is lined by what? Pseudostratified ciliated columnar epithelium. No doubt. Pseudostratified ciliated columnar epithelium only. But the bronchioles, here one important exception is that the bronchioles are lined by ciliated cuboidal epithelium. The alveoli, which are a part of respiratory zone, alveoli, the respiratory zone, already I have discussed with you, they are lined by the simple squamous epithelium. Okay, so trachea are lined by trachea are lined by pseudostratified ciliated columnar epithelium, conducting zone. Bronchioles is little different. Okay, certain part of the bronchioles they are lined by the ciliated cuboidal epithelium, but the respiratory zone where gas exchange will happen, lined by simple squamous epithelium. Completed. Next, this is also done. See, there is a non-ciliated MCQ. Ask long back in NEET PG and FMGE exams. There is a non-ciliated cuboidal epithelial cell in the respiratory tract. In the respiratory tract, there is a one cell which is a non-ciliated but cuboidal. The cell is called as a Clara cell. Okay, Clara cell, sir. And what is the important point about the Clara cell? Already we have discussed. Clara cell is a stem cell. It helps in the detoxification. Actually, it helps in the detoxification. Next, what is the Boyle's law states us? The entire respiration depends on the Boyle's law, right? What is Boyle's law stating us? Boyle's law states us pressure and volume are inversely proportional. When you increase the volume, pressure decreases. When you decrease the volume, pressure increases. Simple. Imagine, let's take a balloon. Okay, imagine it's your birthday. Now someone gave you a balloon. Now you take this balloon and let's try to compress it. What exactly you are doing? You are trying to compress it. So you are decreasing the volume. Whenever you decreases the volume, what happened to the pressure inside the balloon? Increases. So decreasing in the volume increases the pressure. So Boyle's law states as volume and pressure are inversely proportional. Okay. What is the intrapleural pressure at rest? Can you tell me? I'm at rest. I'm not inspiring. I'm not expiring. I'm at rest. What is the intrapleural pressure? The intrapleural pressure is going to be minus 2 mm of Hg. Okay, minus 2 millimeters of mercury. Minus 2. Intrapleural pressures are always negative. Don't forget. Intrapleural, in between the pleura, there is a vacuum, sir. This minus 2 is actually vacuum. Intrapleural pressures are always negative. Why it is always negative? Now we can't discuss because of something called as dynamic harmonious antagonism. It will be always negative. Why? Because always lung want to collapse, chest wall want to expand. So there are two different opposite forces. I don't want to discuss now. Simple. Intrapleural pressure in between the pleura, the pressure is always negative during rest. Okay, during rest it's always negative. And how much? Minus 2 mm of Hg. Now what is the intraalveolar pressure? I am like this. I am not inspiring. I am not expiring. I am like this. What is intraalveolar pressure? 0. Outside, inside it is equal. It is 0. During inspiration it becomes minus 1. See, I am inspiring. Inside it becomes minus 1. Outside it is 0. So 0 is higher than minus 1. During inspiration, see, during inspiration, do you know what happens to the intraalveolar pressure in my lungs? The intraalveolar pressure becomes minus 1. Means getting negative. So outside 0, inside minus 1. So from high to low, air enters. So remember, intraalveolar pressure, IAP, during inspiration is minus 1. During expiration, inside it will become plus 1. So air will come out. Done. Now transpulmonary pressure, sir. Very important. What is this transpulmonary pressure? Look, very simple. Imagine this is your alveolus and this is the pleura. See, imagine this is your intrapleural space. In the intrapleural space, the entire lung I am showing as an alveoli. Okay, alveoli. See, inside the alveoli, the pressure is 0. Intraalveolar pressure is 0 at rest. Here it is how much? Minus 2 mm Hg. So what is the difference? Intraalveolar pressure 0 minus 2.0 minus of 2. How much? Is plus 2 mm Hg. Okay, so that's the transpulmonary pressure. So what is the transpulmonary pressure? It's the intraalveolar pressure minus intrapleural pressure. Intraalveolar minus intrapleural pressure is the transpulmonary pressure. How much it is? It is plus, it's the distending pressure. It actually, this is the pressure which is keeping my alveolus open. It's a transpulmonary pressure. which is keeping my alveolus open. So simply tell me what are the important MCQs. Just a recap. Surfactant is stored in lamellar bodies. Hyaline membrane disease in newborn. It is because of deficiency of surfactant. Trachea is lined by pseudo stratified ciliated columnar epithelium. Bronchioles are lined by, this is one exception, they are lined by ciliated cuboidal epithelium. Alveoli are lined by simple squamous epithelium. Non-ciliated cuboidal epithelial cell in your respiratory tract is a Clara cell, which is a stem cell, helps in the detoxification. Okay, and Boyle's law. Boyle's law is volume and pressure are inversely proportional. Intrapleural pressure is always negative, -2 mmHg. Intraalveolar pressure during rest it is 0. During inspiration -1. During expiration it is +1. Transpulmonary pressure is +2 mmHg. It is the difference between, okay, it's the difference between intraalveolar pressure minus intrapleural pressure. It's a difference, 0 minus of -2. It's a +2. Okay. Next. Come on, guys. Guys, is it okay? Shall I go forward? Shall I go forward? Hello, buddies. Shall I go forward? Simple, trust me. You go through all these rapid revisions. Okay, yes, it will be somewhere around 10 hours to 11 hours. But worth watching. Not only just from physio, we have integrated. All the questions will be done. Okay. Next, if you are really good students, by this time you should have answered these questions by yourself. Can you tell me what is the major inspiratory muscle? Diaphragm, sir. Now, if you are really good with your anatomy, okay, can you tell me what is the nerve innervating the diaphragm? The nerve innervating the diaphragm is the phrenic nerve. What is the root value of the phrenic nerve? Phrenic nerve is coming from which segments of the spinal cord? Phrenic nerve, the root value is going to be C3, C4 and C5. C3, C4 and C5. Major inspiratory muscle is, okay, diaphragm. There are other accessory muscles at this point of time. You don't need to remember. There are other accessory muscles like sternocleidomastoid, scalene muscle, sectional intercostals. Right now, not needed. Remember, major inspiratory muscle is the diaphragm. Inspiration is the active process. During, like, forceful inspiration, there are muscles like sternocleidomastoid, scalene muscles, external intercostals. They will also help in inspiration, but they are accessory, not major. Accessory. Okay. Phrenic nerve. What is the root value of phrenic nerve? C3, C4, C5. Expiration, is it active or passive? Expiration is passive. Expiration is passive process. For forceful expiration, something like that. Forceful. Like when you will be doing forceful expiration, for example, today is your birthday. You have to blow. You have to blow out the candles. Okay? Or while blowing the balloons, your friend birthday, you are blowing the balloons. So forceful expirations. So forceful expiration is active. Okay, forceful expiration is active, but normal expiration is passive. MCQ is during forceful expiration, which muscle is most important? It's the rectus abdominis. It's the rectus abdominis, the six-pack muscle. The rectus abdominis is inwards, a major muscle in the forceful expiration. Forceful expiration. What are the collapsing forces of lung? Simple. Which forces are restricting the lung expansion? What is lung expansion? The stretching of the lungs. The distension of the lungs is called as compliance, you know. The stretching of the lungs is measured with the compliance. Simple, lung is stretching. Who is opposing it? What are the two forces who are opposing the lung expansion? Two forces are there. One is surface tension. It is a collapsing force. Second one is elastic recoil. The lung is made up of elastin fibers and collagen fibers. So the collagen fibers and elastin fibers, one, as well as the surface tension because of surface tension which is there inside your alveoli. Surface tension is all the time there because of the air-water interference. They are the collapsing forces. So now the 90 answer, look here. Very, very important. The opposing forces for the lung expansion, one is the surface tension, it will try to collapse the alveolus. The second one is the elastic recoil because of elastin fibers and collagen. Your lung is made up of elastin and collagen, they will cause the collapsing of the alveoli. Next, compliance of the lung. Okay, compliance of the lung. How compliance is not simple but stretching. How much easily stretchable your lung is. If you give little amount of pressure, for example, 1 centimeter of water. Okay, 1 centimeter of water pressure. I'm talking about the centimeters of water here, not mm of Hg, centimeters of water. If you give this much amount of pressure, 1 centimeter of water pressure, lungs will expand, lungs will stretch, lungs will distend by 200 ml. 200 ml. So with 1 centimeter of water pressure, the compliance of the lungs, the stretchability of the lungs is 200 ml or 0.2 liters. Okay, 200 ml is nothing but 0.2 liters, right? So that's how compliant my lungs are and your lungs are in a healthy individual. Okay. Then compliance of the lung already we have completed. Next, what are the other MCQs? So 90 completed. Compliance of the lung is also completed. Okay. Volumes which are not measured by spirometry. You know, right? There are different types of volumes. Tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume, and there are certain capacities also. Okay, here I am talking about both volumes as well as capacities. Volumes plus capacities which are not measured. There is a study called as spirometry. With the spirometry, which volumes you cannot measure? This is MCQ. See, with spirometry, you cannot measure three things. What are they? Are first thing, you cannot measure the residual volume. You cannot measure the functional residual capacity. Let me show you here. See, lung volumes which are not measured are first one, residual volume you cannot measure. Whatever you do it for, first of all, what is residual volume? I hope you already know this. Whatever the force you do, whatever the effort you give, certain amount of gas, certain amount of air will never come out of your lungs. It will never ever come out of your lungs. Whatever you try, it will only come out if you simply just lie down your back, ask a big elephant to come and have, like, you know, it is standing on your chest, then only it will come, then only your lungs will be compressed, then only residual volume will come. Otherwise it will never come out. Okay, so residual volume, it will never come out, sir. Without knowing the residual volume, you cannot calculate the FRC. Without knowing the residual volume, you cannot calculate the total lung capacity. So which volume you cannot calculate? Residual volume you cannot calculate. And which capacities you cannot calculate? Functional residual capacity and the total lung capacity. They are not calculated. Answer. Now, resting lung functions at resting lung. Right now, see. I'm not inspiring. I'm not expiring. I'm just like this. What is the volume of air that is present inside my lungs? The volume of air that is present in my lungs, now it is called as functional residual capacity. Okay, functional residual capacity. So, this functional residual capacity, what is the formula? See, the functional residual capacity, the formula is residual volume, it cannot come out, it will be all the time there, and expiratory reserve volume. Okay, this expiratory reserve volume and residual volume. Okay, expiratory reserve volume and residual volume, if you add them both, they will give you FRC. So simply tell me, I am like this, at rest. What is the volume of air that's present inside my lungs? It is functional residual capacity. So during rest, my lungs are working at functional residual capacity. What is functional residual capacity? It includes residual volume and expiratory reserve volume. Done. Now, many times this question has been asked, very, very important, especially for FMG as well as PG. How to calculate this FRC, sir? Functional residual capacity, and even this residual volume also, functional residual capacity and this residual volume, how to calculate is helium dilution technique. Okay, helium dilution technique and body plethysmography. Here also see helium dilution technique, body plethysmography, both same things, and multiple breath nitrogen washout method. See, they are the ones here I have already given you. See, these are the methods. Helium dilution technique, the best method to calculate the functional residual capacity is body plethysmography. Previously asked NEET PG MCQ. Body plethysmography is the best test to measure functional residual capacity. And even to measure the residual volume, single breath nitrogen washout method, helium dilution technique, body plethysmography, they are used to measure residual volume. Done. So with this, completed. Okay, guys, is it clear? Mountain Life, Vijay Kumar. Is it okay? Shall I go forward? Already this I have discussed. What is causing the collapsing of the lungs or the recoiling of the lungs? The two collapsing forces already I have discussed. Is the surface tension as well as the elastic recoil. Surface tension and the elastic recoil because of the collagen as well as the elastin. Okay, this is done. Now, look here. If I am the examiner, I will give a question from here, definitely. See, here I am discussing about the complaints. Okay, here I am discussing about the complaints. Complaints of the lungs. This graph is called as the pressure volume loop. Now, if I go in detail, you will definitely get confusion. No doubt. Because you don't know, I hope you have already know this. Simple, I will ask you two questions. When the lung is more complaint, this is the complaints curve. This is the complaints. This curve or this graph is showing the complaints of a lung. This is the complaints of the lung during inspiration. This is the complaints of the lung during expiration. First tell me, the complaints of the lung during inspiration and expiration are the same? Are the same? No. There is a difference in the path. Okay, there is a difference. So complaints of the lung during inspiration and during expiration, the same lungs we have. We are having the same lungs. But the compliant nature of the lungs during inspiration, during expiration is absolutely different. Okay. Now tell me, when lungs are more compliant, right? Lungs are more compliant during expiration. Okay, lungs are more compliant during respiration. First of all, this graph is a compliant graph. You should, whenever you see this, you should know why we are saying it as a compliant graph, because the compliance formula is delta V, change in volume. See, here I am talking about the voluminous change. Here I am talking about the pressure change. So delta V by delta P. Why I am telling you this like delta V and delta P now? Why? Because later we will understand the next slide. So delta V by delta P, whenever you see this formula, delta V by delta P, it will give you which graph? It will tell you about the compliance. Now look here, the compliance during inspiration is towards the lower side and the compliance during expiration is towards the higher side. So mostly students will think, sir, lungs are stretching during inspiration, so lungs are more compliant during inspiration. No, the lungs are more compliant during expiration and lungs are less compliant during inspiration. So there is a difference, right? In the complaints, there is a difference. This difference is called as what? This difference is called as hysteresis. So the difference in the compliance of the lung during inspiration and expiration is called as the hysteresis. And this hysteresis is due to what? Why? Why the compliance is changing, sir, during inspiration and expiration? If you ask me, the difference is because of surface tension. Surface tension. So let me write here, during inspiration, do you know what happens in lung? Surface tension increases during inspiration. See, I'm doing inspiration. No, do you know what happens in my lung? During inspiration, surface tension is more. Why more? This is not the time. During inspiration, the surface tension is more. Whenever the surface tension is a collapsing force. Whenever surface tension is more, the compliance is less. So less compliant. During expiration, okay, during expiration, whenever there is expiration, the surface tension decreases. Okay, surface tension decreases, lungs are going to be more compliant. Okay, during inspiration, expiration, compliance changes. Expiration more compliant, inspiration less compliant. The difference between these pathways is called as a hysteresis, and the hysteresis is due to surface tension. The surface tension during inspiration and expiration differs. Like, it's different. Why? Here is the explanation when I share the PDF. Okay, when I share the PDF, you can study. Okay. Now, after this, the three graphs which I want you to know. Very, very important, sir. I'm the examiner, I will definitely give. Especially this is a little integrated with the medicine also, as well as medicine as well as path also. Now, let's take this blue color dotted line as average complaints or the normal complaints. Normal healthy person complaints. See, this pink color graph, what is happening? The complaints is increasing or not? When compared to the normal complaints, now in this person, the complaints is increasing. The graph is shifting towards the upper side or to the left side. So the complaints is increasing. The slope of the graph is increasing. Complaints increases. In which condition? In emphysema, sir. In emphysema, complaints increases. Okay. Hope you have already studied. In emphysema, the patient is having large voluminous lungs, barrel-shaped chest, hyper-resonance is seen. Big lungs are seen. So that's why more complaint lungs, bigger lungs. Okay. So emphysema patients have increased complaints. Now in the second example, see the complaints is falling down. The slope is decreasing. In which condition complaints decreases? Complaints is going to be decreased in the pulmonary fibrosis. Pulmonary fibrosis. In atelectasis. Oxygen hemoglobin association dissociation curve, Jenny will discuss about that within a minute. Okay. Oxygen hemoglobin association dissociation curve. Yeah. We'll discuss about that. Okay. Now I just want to don't deviate from the topic. We'll discuss oxygen association dissociation curves. Yeah, here it is there. We'll discuss. Okay. Now, where I am? Here's. So emphysema, the complaints increases. In pulmonary fibrosis, see, lungs are fibrotic lungs. Now small lungs, fibrotic lungs. Now they are not stretchable. So compliance or stretchability decreases. Next MCQ is, this is the one. If your lungs are filled with the saline, see, saline filled lungs. If your lungs are filled with the saline, what happens? Saline filled lungs, theoretical. Okay, not a practical thing. If you fill your lungs with saline, what happened to the complaints of the lungs? Look here. This is the normal person complaints during inspiration, during expiration, the complaints curves. And the difference between them is called as a hysteresis, we know. See, this blue color thing. What happens? Increases, sir. The complaints in saline filled lung increases. Why? Why? Because your entire lungs are now filled with the saline. There is no air entering into your lungs. There is no air-water interference. Whenever the air is going into your lungs, whenever there is air and water interference in lungs or alveoli, surface tension develops. But now when your lungs are filled totally with saline, there is no such thing as air and water meeting point. Air and water interference is not there. Whenever there is no air-water interference, there is no surface tension. Whenever surface tension, collapsing force, whenever it is not there, whenever it is not there, now it is very easy to stretch the lungs. Collapsing force is not there. Now it is easy to stretch the lungs. So, see, the compliance increases. Not only compliance increases, I have taught you, surface tension is not there. So this difference, hysteresis is also now very minimal. So whenever you see such a graph is indicating the compliance of lung in saline filled patient. In saline filled lungs, compliance curve is having more slope. Compliance increases, and hysteresis, the difference is also less. Okay. Now, after this, if your time is bad, okay, then such kind of questions will come. Like, the calculated questions. One calculation I want you to know. I have already taught you. Delta V by delta P. Delta V means what? Change in volume by change in pressure. For a given pressure, see, try to understand like this. I am giving little pressure. More volume is changing, which means more compliance. I am giving more pressure, but only little volume change. Only little volume change, not compliance, sir. So, delta V, change in volume according to the change in pressure, delta P. Will tell you what? Will tell you the compliance of a lung or compliance of any particular substance. So delta V by delta P is a formula for compliance. Now in a question they will give you the tidal volume that the patient is taking is 500 ml. Okay, we know this. And the intrapleural pressure that's changing during inspiration. Okay, during inspiration the intrapleural pressure changes. The intrapleural pressure, it is changing from maybe from -4. The intrapleural pressure is -4 centimeters of water. Always it's -4 centimeters of water. It is changing to -8 centimeters of water, for example. So what is the volume change? Volume change is 500 ml of lungs are expanded. 500 ml volume air enters into the lungs. For how much change in the pressure? The change in pressure is 4 centimeters of water. So 4 divided by 500, how much? 4 divided by 500 is 125. Okay, 125. Okay, so that's the compliance. Okay, for which means for every 1 centimeter of water pressure, for every 1 centimeter of water pressure, this much volume of the lungs are expanded. Okay, this is the compliance. So simply tell me, what is the compliance formula? The formula for the compliance is delta V by delta P. When the lungs are more compliant, during inspiration or during expiration? During expiration, lungs are more compliant. In a saline filled lungs, if you fill your lungs with saline, compliance increases or compliance decreases? Compliance increases. Okay, compliance increases. This is the graph. Okay, more slope will be there. Hysteresis, the difference. Okay, see this difference. Here more difference is there because of surface tension. See here, there is no surface tension. If you fill the lungs with cell lines, surface tension is not there. So hysteresis also decreases. In emphysema, more compliant or less compliant? Lungs will become more compliant. In pulmonary fibrosis, what happened to the compliance of lung? Compliance of the lung decreases. Okay, next question is, I have removed my lungs out of my thoracic cavity, out of my chest cavity. I have removed my lungs. Now I am keeping my lungs here. Now, what happened to the lung volume? Lung volume is going to increase after taking the lungs out of my chest. The lung volume increases or lungs will collapse. Lung volume decreases. What do you think? Lung volume increases or lung volume decreases? See, normally your lungs, with the help of pleura, they are attached to chest wall. Your lungs, see now this is the lung. Your lung is attached to chest wall. Your chest wall all the time want to expand the lungs. Now, right now I am at rest, right? Say I am at rest. My chest wall, it all the time want to expand out. It all the time want to expand out. So this chest wall, from all the sides, it is stretching the lungs. Okay, it is stretching the lungs. It's keeping the lungs open. It's stretching the lungs. But the moment you take the lungs out of my thoracic cavity, from my chest wall, what happens? Now lungs, because of elastin fibers, now the chest wall is no longer expanding. Okay, chest wall is no longer expanding the lungs. So what happens now is lungs will start to collapse. So lung volume decreases. MCQ. This was the MCQ. So this kind of hypothetical questions will also be asked. So if the lungs are removed out of the thoracic cavity, what happened to the lung volume? Lung volume decreases. Okay, lung volume is going to be decrease. Guys, there is a little technical issue. Just a break of 1 minute. Okay, within 1 minute, we'll just start back. Okay, 1 minute break. Started. Okay. Okay, Gajendra Yadav. Me too. Okay, me too. Now, let's do some direct single error kind of questions. Now, what's the partial pressure of oxygen in the environment? These are basic direct single error questions. Yeah, it will be better if you know this. What's the partial pressure of oxygen in the environment? It is 104 mmHg. In the oxygen, sorry, in the environment, oxygen is there, no? This oxygen entire pressure of the atmosphere is 760 mm of Hg, we know it. What is the partial pressure of oxygen? Oxygen pressure is 104 mmHg. What is the partial pressure of oxygen in the alveoli? Oh, sorry. Sorry. This is not 104 mmHg. It will be 160. Okay, here, yeah, directly I will show you here. See, it's 160. That's my mistake. Yeah, I got a little confused. So partial pressure of oxygen in the environment is 160 mmHg. Okay, so what is partial pressure? The pressure exerted by an individual gas like oxygen, nitrogen, carbon dioxide. So what is the partial pressure of oxygen in the environment is 160 mm of Hg. The partial pressure of oxygen, P capital AO2, the partial pressure of oxygen in the alveolus. In the alveolus, it is 104 mmHg. Okay, these are the constant values. Round figure, remember 100 mmHg. Now, in a normal healthy individual, physiological dead space is equivalent to, I am a healthy individual, I hope I am. In a normal healthy individual, there is something called as physiological dead space, anatomical dead space. See, in a healthy individual, the physiological dead space is equal to anatomical dead space. Okay. See, anatomical dead space is nothing but, you know, the conducting zone is there, right? The first, like, you know, these areas where there is no exchange of gases. So, the conducting zone is the area where there is no exchange of the gases. So, it's considered as a dead space. How much ml? 150 ml. 150 ml. In a healthy individual, the same anatomical dead space is the physiological dead space. So, anatomical dead space and physiological dead space, they are just 150 ml. Okay, there is no such thing as pathological dead space. Okay, next, ventilation perfusion ratio. Favorite question. Okay, see, the ventilation perfusion ratio of the lung is how much? Direct one single value if you want to say. So, the ventilation perfusion ratio of a lung is 0.8. That's it. Ventilation perfusion ratio is 0.8. But the ventilation perfusion ratio is different in the apex of the lung, in the base of the lung. Ventilation perfusion ratio is maximum in the apex. How much value? 3.2. Some books mention 3.3, 3.4. The ventilation perfusion ratio in the apex of the lung is 3.2. In the base, how much, sir? In the base, it is a minimum. In the base, it's going to be 0.6. Okay. In the apex, it is 3.2. In the base, it is 0.6. But generally, if someone asks you, ventilation perfusion ratio, V by Q, ventilation means V, Q means the perfusion. V by Q ratio, ventilation perfusion ratio is going to be 0.8. Okay. In the apex, it is 3.2. Maximum in the apex, least in the base. Okay, least in the base. Done, sir. See, perfusion is maximum in, I am showing you my lung. Okay, in this lung, apex, middle lobes as well as base. Where do you think more blood supply will be there? Maximum perfusion. Base or in the apex? Remember, the base of the lung is having maximum ventilation as well as a maximum perfusion. Maximum ventilation and perfusion. Okay, perfusion plus ventilation also are maximum in the base. Okay, the base, both ventilation as well as perfusion, both are maximum, no doubt. Measurement of diffusion of gases. Diffusion of the gases. Oxygen diffusion, carbon dioxide diffusion, carbon monoxide diffusion. The diffusion of these gases is measured by using a study. Do you know what is a study called as? A study is called as a DLCO. Diffusion lung capacity using carbon monoxide. Diffusion in the lung measured by carbon monoxide, DLCO. Which gas we are using? Carbon monoxide. Why? Because carbon monoxide have more affinity with the hemoglobin. So what is the study for diffusion? DLCO. Question is, in which condition DLCO is going to be decreased and in which condition DLCO, diffusion in the lungs In which condition diffusion increases, sir? In which condition diffusion decreases, sir? See, diffusion first decrease in DLCO. Diffusion is decreasing in which condition? Emphysema. Okay, in emphysema, the alveolar septa, because of excessive protease activity, the alveolar septa are going to be damaged. As alveolar septa are damaged, the surface area decreases. In emphysema, the surface area of the alveoli decreases. Because of that, diffusion decreases. So, DLCO or the diffusion is decreased in which disease? Emphysema, as well as pulmonary fibrosis. Lungs are fibrotic, alveoli are fibrotic. Now, when the alveoli are fibrotic, the alveolar basement membrane is now thick, fibrotic alveoli. Do you think diffusion will happen properly now? Diffusion decreases. So, DLCO, it is decreased in which conditions? Emphysema as well as fibrosis. But in which conditions, under which conditions more and more diffusion will happen? Diffusion, let me add one more thing, decreased diffusion is going to be seen in anemia. Okay, anemia. Anemia means what? No hemoglobin. Hemoglobin, not enough amount of hemoglobin is going to the lungs. Hemoglobin is the one which binds with the carbon monoxide. If hemoglobin is not going, diffusion decreases. So in anemia, diffusion decreases. Emphysema, diffusion decreases. Pulmonary fibrosis, DLCO decreases. But in which condition diffusion increases? Is polycythemia. Okay, polycythemia means what? More RBC, more hemoglobin is going there to the lungs. So it will rapidly take the carbon monoxide. So more diffusion will happen because of the gradient. More and more diffusion will happen. Next, exercise. Okay, exercise means there will be vasodilation. More blood will be going to the lungs for the purpose of oxygenation. More oxygen demand is there, right? Whenever you are doing exercise. So during exercise and during polycythemia, DLCO increases. Okay. Next step. The anatomical dead space I have already discussed with you. Anatomical dead space is equivalent to physiological dead space. Anatomical dead space is measured by lots of times question asked. FMGE exam, NEET PG exam, INSET, all exams. How to calculate anatomical dead space? Remember one word, Fowler's method, also called as single breath nitrogen method. Single breath nitrogen method. See, now let me show you. Residual volume, also we have discussed. See, residual volume, it is a multiple breath nitrogen washout method. Okay, multiple breath, same thing. Here it is a multiple breath nitrogen washout method is used to measure residual volume. But for the calculation of anatomical dead space, there is a single breath nitrogen washout method which is used, which is also called as Fowler's method. And what is the formula used for the calculation of physiological dead space? Physiology, boring subjects or something like that. You're saying? So, Bohr's equation. So, physiological, remember, physiological dead space, it is measured with Bohr's equation. Okay, Bohr's equation. The formula for Bohr's equation is VD by VT. VD by VT, dead space, the dead space calculation. VD by VT is equal to PaCO2 minus PeCO2 by PaCO2. PaCO2 minus PeCO2 by PaCO2. I used to remember something like that. Okay, PaCO2, something like PaCO2. Okay, PaCO2, PaCO2. So, PaCO2 minus PeCO2 by PaCO2 will give you, this is the formula. If you time bad, such kind of questions, such kind of calculations will come in your exam. But don't worry. Okay, most of the time FMGE exam, they won't ask you to do simple. Bohr's equation is used to calculate the physiological dead space. And anatomical dead space is calculated by Fowler's method. Last. We came last. This completed, all these questions are also completed. Now, here, I want you to know one thing. See, this is the apex of the lung. This is the apex lobe of the lung. Okay. This is the middle lobes of the lung. Okay. This is the base of the lung. Okay. Where maximum blood flow is there, maximum perfusion. See, in the base of the lung, concentrate, there is a continuous blood flow. Only this one point I want you to know. Why there is continuous blood flow? There is a reason. Okay. Why? Because the arterial pressure, pulmonary artery pressure is greater than the pulmonary venous pressure than the alveolar pressure. There is a reason, but I don't want you to go now in that detail. Base of the lung, there is continuous blood flow. Continuously base of the lung is getting perfused. More and more blood is going there. Because more pulmonary artery pressure. The pulmonary artery pressure in the base is more. So the continuous blood is going. In the apex of the lung, topmost areas of the lung, there is least blood flow, almost nil. In the apex of the lung, there is least blood flow, MCQ. Why? Because the alveolar pressure, the alveoli are having more pressure. This alveoli is actually compressing the blood vessels. See, in the apex of the lung, if you look here, the alveoli, because of the more alveolar pressure, it's actually compressing the pulmonary capillaries and the pulmonary arteries. So, the alveolar pressure, P capital A, means alveolar pressure is more. But in the base of the lung, the arterial pressure is more, P small a. But in the middle lobe of the lung, this is called as the watershed area. Okay, this is called as the waterfall effect, where sometimes blood flow happens, sometimes doesn't happen. Intermittent blood flow. Okay, a medium range thing. Okay, so the middle lobe is the intermittent blood flow area. Why? Why? Because see here, yes, pulmonary artery pressure is more than, okay, see, pulmonary artery pressure is more than pulmonary artery pressure is more than the alveolar pressure. Okay, pulmonary artery pressure is more than the alveolar pressure. But compare the base as well as the middle. If you compare the base as well as the middle, see, in the base of the lung, pulmonary artery pressure is more than the pulmonary venous pressure. Even this pulmonary venous pressure, even the venous pressure is greater than the pulmonary artery pressure. So here the, not artery, alveolar pressure. So here the alveolar pressure is least. But in the middle lobes, yeah, pulmonary, this alveolar pressure. Okay, this capital A means alveolus. Alveolar pressure is little more than the venous pressure. So simple, man. No need to remember in that much detail. Simple MCQ. In the apex of the lung, least blood flow. Okay, why? Because the alveolar pressure is more, compressing the blood vessels. In the base of the lung, there is continuous blood flow. Okay, there is continuous blood flow because pulmonary artery pressure is greater than the pulmonary venous pressure, greater than the alveolar pressure. The middle lobes are called as the intermittent areas, zones of intermittent blood flow. Okay, this is called as a waterfall effect. Here in the middle lobes, pulmonary artery pressure, yes, it is greater than the alveolar pressure, but the alveolar pressure is greater than the pulmonary venous pressure. Okay, if you can remember, you can remember it. That's good. Okay, and already I have taught you the ventilation perfusion ratio in the lung. The ventilation perfusion ratio V by P. The ventilation perfusion ratio is 0.8. In the apex, it is 3.2. In the base, it is 0.6. Okay, already I have discussed. Two important MCQs which I want you to know is, look here and tell me. This is the lung. In the lung, please tell me the alveoli which are present in the apex, they are bigger in size, right? So larger alveoli is present where? In the apex. So in the apex, the alveoli size is more, and in the base, okay, if you look at the base of the lung, what about the alveolar size? In the base, they are small. Small alveoli are present in the base of the lung. Remember that thing, one difference. So apex contains the larger alveoli, base contains the smaller alveoli. Apex, already I have taught you, the ventilation perfusion ratio is 3.2. In the base, there is the ventilation perfusion ratio is 0.6. Okay, just only know these things. Other things I don't want you to remember. Okay, main areas I am concentrating, main areas. And next important point is this. With this, if you know this, enough. Respiratory physiology, all the important points are completed, will be completed. What is this graph, sir? First point number 1. This is oxygen hemoglobin association dissociation curve. Okay, oxygen hemoglobin association dissociation curve. Now the blue color thing, whatever is there in the middle, this fellow, the blue color one, this is normal. Okay, there are certain conditions where there will be right shift. The curve is shifting towards right, and there are certain conditions where the curve is going to shift towards the left. There will be a right shift, there will be a left shift. First, number 1 question, especially in the board exams, Indian exams, like in USML exams, they will ask you, what is the shape of this graph, oxygen hemoglobin association dissociation curve? The shape is going to be sigmoid in shape. It's not a straight line like this. It's a sigmoid. Why? Because of a phenomenon called as positive cooperativity. Okay, there is something phenomena called as a positive cooperativity. I don't want to go into the phenomena. The hemoglobin have 4 sites of oxygen binding. Binding of one oxygen molecule will cooperate the binding of the other oxygen molecule. Simple. I don't want to go there. Simple. The oxygen hemoglobin association dissociation curve, the shape of this curve is sigmoid because of a phenomena called as positive cooperativity. Okay. Next step. How many changes can happen? There will be a right shift, there will be a left shift. Okay. So what is this right shift and left shift? Let me tell you in a simple way. I will also give you a little like an explanation for you to understand. At the level of tissues, see, normally at the level of tissues, at the level of lungs, the oxygen saturation, see, the oxygen saturation is 100%. Okay, the oxygen saturation is 100%. Okay, at the level of lungs. The not oxygen saturation, the hemoglobin saturation. Hemoglobin is having all 4 molecules of oxygen attached. Let me tell you, look at the blue one at 40. Okay, look here. In your tissues, the partial pressure of oxygen is 40. Now tell me, when the partial pressure of oxygen in the tissues, when it is 40, hemoglobin is how much percent saturated? Hemoglobin is 75% saturated. Okay. Now, think logically. 75% saturated means only 1 oxygen molecule is delivered. Normally, 4 oxygen molecules should be there with the hemoglobin. 4 oxygen molecules. When the 4 molecules are there, you can say it is 100% saturated. Normally, in a normal resting man like me, for example, I am resting. Now, at the level of my tissues, the partial pressure of oxygen is 40 mmHg. When the partial pressure of oxygen at my tissues is 40 mmHg, hemoglobin will release 1 oxygen. It will release 1 oxygen to the tissues. So, hemoglobin will become 75% saturated now. Why? Because 1 oxygen molecule is delivered. Now, imagine after the class, I am going onto the streets and I am running. Okay, I am running. When I am doing exercise or when I am sprinting, when I am doing exercise, what hemoglobin should do? My metabolic demands are more. My muscles need more oxygen. So hemoglobin have to deliver more oxygen. Instead of delivering 1 oxygen, now hemoglobin, very good molecule, it will deliver 2 oxygen molecules. So that is called as a right shift. So under certain conditions like exercise, when body temperature increases during exercise, when carbon dioxide levels increases during exercise, when the pH increases during exercise, all these things will bring the change in the nature of hemoglobin in such a way, now it will become a good donor. Instead of delivering 1 oxygen molecule, it is delivering 2 oxygen molecules. Now same thing, see in the graph. Now for the same 40 mmHg pressure, okay, for the same 40 mmHg pressure, look, what is happening on the green? What is happening to the hemoglobin saturation? It is coming to 50. Hemoglobin saturation from 75, it came to 50, which means instead of 1 molecule being delivered to the tissues, now 2 molecules are getting delivered. Means more oxygen is getting released, more oxygen is available to the tissues. Okay, that's it. So whenever you are not doing any work, for example, now you are hibernating, your tissues doesn't need any oxygen, then hemoglobin will say, if you don't want any oxygen, I won't deliver any oxygen. So there will be right shift. Okay, so under certain conditions, like when your body temperature decreases, your metabolic activity decreases, whenever there is alkalosis, there are certain conditions which can cause left shift in the oxygen hemoglobin association dissociation curve. Now look, for the same 40 mmHg pressure, okay, now look here, at the same 40 mmHg pressure, now in this individual, how much is hemoglobin saturated? Hemoglobin is now almost maybe 90% saturated. 90% saturated, which means not even 1 molecule is delivered. Not even 1 molecule is delivered. Why? Because tissues are not asking for oxygen. Tissues are not having any metabolic activity. The body temperature is less. The pH is more. Okay. The carbon dioxide levels are less. Now in this condition, the oxygen hemoglobin association dissociation curve shift to right. Okay. So now, at the end of the day, even if you understand the concept, doesn't understand the concept, simply by heart this thing. What is that? Right shift means during exercise, more oxygen is getting delivered, which means it's a low affinity state. Hemoglobin is not loving to bind with oxygen. Now, hemoglobin doesn't want oxygen. Hemoglobin is delivering the oxygen. So, low affinity. So, right shift is considered as a low affinity state. Seen in which condition? In exercising conditions. Whenever there is hypercarbia, more carbon dioxide in the body. Whenever there is hypoxia, acidosis, low pH or more proton concentration. Whenever the body temperature increases or whenever there is production of this 2,3-BPG, 2,3-bisphosphoglycerate, the production of this 2,3-bisphosphoglycerate molecules in the RBC can also cause right shift. So simple, right shift, low affinity state, more oxygen delivering to the tissues. Which conditions? Exercising muscle, hypercarbia, more temperature, low pH, more proton concentration, 2,3-BPG, more temperature. Right shift. Exact opposite thing is left shift. Left shift means hibernating. Okay, simple, no activity in the body, low temperature. Now hemoglobin will say, tissues don't want oxygen, I won't deliver oxygen. Simple. So left shift is a high affinity state, which means the hemoglobin is totally binding with the oxygen. In which conditions? Whenever the temperature, body temperature decreases, and the conditions like alkalosis. Alkalosis means the proton concentration is less, the carbon dioxide concentration. All these are the low metabolic activities. Okay, seen in the low metabolic activities, carbon dioxide less, proton less, alkalosis, body temperature decreases, and fetal hemoglobin, especially in the fetus. In the fetus, there will be this fetal hemoglobin. This fetal hemoglobin is an example of high affinity state. It tightly binds with oxygen. Okay, why? Because fetal lungs are not mature. This the kind of hemoglobin which is present in the fetal RBCs is this fetal hemoglobin with the gamma chains. They will tightly go and bind with the oxygen in the placenta. Okay, so now tell me, left shift is seen in low temperature, high body pH, or low proton concentration, or alkalosis, or fetal hemoglobin. Okay, so these are the things which I want you to know. So tell me, oxygen hemoglobin association dissociation curve have two shifts, right shift as well as left shift. So these are the important points. And so the last slide, in the respiratory thing, most of the oxygen is transported in the which form? Okay, you have taken the oxygen. Now this oxygen, where it have to go? It have to go to the tissues. Most of the oxygen is transported in which form? In dissolved form? No. Most of the oxygen is transported in the form of oxyhemoglobin. So oxyhemoglobin is the major form of oxygen transport. What is the most important form of carbon dioxide transport? The most important form of the carbon dioxide transport is bicarbonate ions, HCO3 minus ions. So HCO3 minus ions are the form of carbon dioxide transport. Already I have discussed this with you. Oxygen hemoglobin association dissociation curve is a sigmoid. It's not straight, it's sigmoid. Why it is sigmoid? Sigmoid, it is due to something called as a positive cooperativity. It's due to the positive cooperativity. Factors causing the right shift, already I have discussed with you. And factors causing the left shift, also I have discussed with you. Okay. So there is something called as a chloride shift. Okay. There is something called as the chloride shift or Hamburger's phenomena. See, this chloride shift or Hamburger's phenomena, what exactly is it is, see, imagine this is your RBC. Okay, let me give you a simple example. These are your tissues. Okay, these are your tissues. Tissues are producing what? Carbon dioxide. Now this carbon dioxide, where it will go? It will come into the RBC. In the RBC, the carbon dioxide will react with the water, helps in the production of H2CO3 carbonic acid. This carbonic acid, it will split into HCO3 minus ions as well as H plus. This HCO3 minus ions, see, this is nothing but the carbon dioxide, right? The carbon dioxide have changed its form to HCO3. Now this HCO3, now where it will come? It will come into the plasma. Okay, carbon dioxide, now it is going to the lungs through the plasma in the form of which ion? HCO3 minus ion. That's why I have shown you here. So what is the most of the carbon dioxide is transported in which form? HCO3. Where? In plasma. In the form of in the plasma. See, when this HCO3 minus, if you want to send this HCO3 minus into the plasma, one HCO3 minus, one negative charge, it is going out of the cell. If you want to send one negative charge out of the cell, in order to maintain the electron neutrality, you have to bring one negative charge into the cell. So in exchange for bicarbonate, chloride came into the cell. This is called as chloride shift. So chloride shift. So chloride shift or Hamburger's phenomena is seen at the level of capillaries in the tissues. Okay. So these are the important points which I want you to know. So with this, respiratory physiology is also completed. All the important topics whichever are needed are completed. So guys, in the next 20 minutes, okay, in the next 20 minutes, please wait, we'll complete the central nervous system also, so that it will be completed. So in central nervous system, okay, in central nervous system, first number one thing which you need to know, see, what you need to keep in your mind? What are the important areas? What are the important areas? See, number one important area is the different types of touch receptors. Different types of touch receptors. In the nerve physiology, the number one area which you need to know is the classification of nerve fibers. Erlanger-Grassy classification, A fibers, B fibers, C fibers. Okay, that's the number one area. In the muscle, you need to know power stroke and the detachment of the myosin heads. You need to know about the titin, desmin, dihydropyridine. They are important. Here in central nervous system, the number one area which you need to know is the types of touch receptors. Okay. Now, how many types of touch receptors are there? The mnemonic is MMRP, like maximum radial pressure is there, right? Like MMRP. In our skin, there are 4 types of touch receptors. What are they? Meissner's corpuscles, Merkel cells, Pacinian corpuscles, and Ruffini sending. See, in our skin, there are 4 different types of touch receptors present. Okay, 4 different types of touch receptors present. Now, these touch receptors, they will detect different forms of touch. What are they? For example, Meissner's corpuscles. Miss means female. With a female, how you have to talk? Rudely or gently? You have to talk very gentle with a miss. So, this Meissner's corpuscles will be activated with a gentle tap. Gentle tapping will activate the Meissner's corpuscles. Gentle tapping. One thing. So, with the female, how you have to talk? With high frequency or low frequency? Gentle with low frequency. So, low frequency vibrations. Vibrations are nothing but a form of touch, right? So, low frequency vibrations, gentle tapping is going to stimulate the Meissner's corpuscles. And these Meissner's corpuscles are going to be maximum in lips and fingertips. In lips and in the fingertip areas, these Meissner corpuscles are going to be more. Done. Next type of touch receptor is Merkel cells. Important point about the Merkel cells is, see, these Merkel cells, they are sensitive to edges and corners. Now, see, now I am able to sense this edge, right? Edge of the table. Okay, edge of the table, corners. Okay. So, which receptors are sensitive to edges and corners, elevations and depressions is going to be the Merkel cells. These are also type of touch receptors. And in your exam, they will ask you, for reading Braille script. Braille script means that elevation, depressions will be there, right? It's a form of script which is used by the blind people. Okay. So, for Braille script, which receptors will be helpful? Again, it's a Merkel cells. So, Braille script, reading, edges and corners, sensitivity is there for the Merkel cells. Next, Pacinian corpuscles, they are the largest capsulated. Now, if you look here, these fellows, see, they are having a capsule, they are having like multi-layered capsule is there, and they are present where? They are present deep inside the skin. Okay, they are present deep inside the skin. So, deep pressure, high frequency vibrations will stimulate the Pacinian corpuscles. They are largest, they are capsulated, they are present deep inside the skin. So, who will stimulate it? Deep pressure, deep touch, high frequency vibrations are going to stimulate the Pacinian corpuscles. Okay, capsulate, largest, deepest, and deep touch and high frequency vibrations. So, these are the points which I want you to know. 3, at least 3. Ruffini sending is I don't want you to know. So, Meissner's, Merkel's as well as Pacinians. Okay. Now, after this, what you should know is these tracts. Every time in your exam, they will ask you, especially from physio as well as anat. Okay, they will be in this question. There is something called as, here, this is the tract. Can you tell me what is this tract which is going in the lateral column? From the spinal cord, this tract is going to the thalamus, and from there it is going to the cortex. This is lateral spinothalamic tract. Lateral spinothalamic tract. See, this lateral spinothalamic tract, it is going to carry which type of information? MCQ. The lateral spinothalamic tract, sir. Come on, guys. Anyone? Bill, Gajendra Yadav, Mountain Life, Jenny. Samantha, Mir. Can you tell me? The lateral spinothalamic tract. Okay, check your anatomy knowledge. The lateral spinothalamic tract is going to carry temperature. Okay, temperature as well as pain. Pain and temperature will be carried by the lateral spinothalamic tract. Okay, MCQ. And here appreciate, there is this tract which is going in the anterior column of the spinal cord. Not in the lateral column, but in the anterior column. It is going from the spinal cord to thalamus. So this is anterior spinothalamic. Anterior spinothalamic tract. This anterior spinothalamic tract is going to carry which type of information? Which type of sensations to the central nervous system? It's going to carry crude touch and pressure. Okay, crude touch and pressure. No, this both lateral spinothalamic tract as well as anterior spinothalamic tract. See, both of them are crossing. They will cross to the opposite side. They are ipsilateral. See, they are not traveling on the ipsilateral side. They are crossing to the opposite side. So they are contralateral. They are traveling in the contralateral side. So both this spinothalamic tract, the lateral spinothalamic tract as well as the anterior spinothalamic tract, they are crossed tracts. The crossing is happening at the level of spinal cord. They are traveling in their contralateral sides. Lateral spinothalamic tract is going to carry the temperature as well as pain. The anterior spinothalamic tract is going to carry the crude touch as well as the pressure. Okay. Now, this kind of questions that will come in your exams. See, this is the kind of question which was asked even in the recent NEET PG exam. Chordotomy of left lateral spinothalamic tract. Okay. See, left side, lateral spinothalamic tract is gone. What will happen? If lateral spinothalamic tract is damaged. Okay, if lateral spinothalamic tract is damaged, temperature and pain will be lost. If left-sided tract is damaged, then right-sided the sensations will be lost. Why? Because the sensations from the right side of the body, they will cross to the opposite side. So if left lateral spinothalamic tract is damaged, right-sided sensations will be lost. Okay, so pain and temperature sensations lost from right side. Okay, that's the point which I want you to know. So, spinothalamic tracts are completed. Okay. Now, there is one more type of sensory tract. Do you know what is that? It's a dorsal column tracts, dorsal column pathways. Hope you have shared this in anatomy also. It will come in physio as well as anat. Dorsal column tracts, which means, see, this is the dorsal column of the spinal cord. Here these tracts are going. Dorsal column tracts, which includes fasciculus gracilis, fasciculus cuneatus. This tract is the fasciculus gracilis and fasciculus cuneatus. Gracilis and cuneatus. The only point which I want you to know is, sir, this dorsal column tracts, they are carrying which type of sensation? They are also taking the information to the brain. But which type of sensation? Fine touch or crude touch? See, advanced sensations. See, now here I am talking about the advanced sensations like fine touch. Okay, very fine touch, a feather, like a feathery touch, fine touch, vibration, vibratory sense, proprioception, stereognosis, 2-point discrimination. All these senses are considered as the advanced sensations. Okay. Now, you know about the stereognosis. I hope you have already know about the stereognosis. Stereognosis means ability to identify the object without looking, ability to identify the object just with tactile sensation. It's looking like a pen, it's looking like a water bottle, it's looking like a book. That's a stereognosis. So, these are the advanced sensations. What are they? Fine touch, vibration, proprioception, conscious proprioception. That's a word is important. Conscious proprioception, stereognosis, and 2-point discrimination. These are the advanced sensations carried by the dorsal column pathways. Next, see, look here, these primitive sensations, like these are the primitive sensations, right? Touch, pain, temperature, pressure, touch, pain, temperature, pressure, touch, pain, temperature, pressure. These are the primitive sensations. All these primitive sensations, see, they are going to nucleus, no doubt, they are going to the nucleus. And even these advanced sensations are also, see, they are coming and even they are going to the nucleus. Sorry, they are going to the thalamus, not nucleus. They are going to the thalamus. Okay. So both primitive sensations, advanced sensations, touch, pain, temperature, pressure, fine touch, vibration, conscious proprioception, stereognosis, all they are going into thalamus, no doubt. But which nucleus of the thalamus is important? To which nucleus, sir? See, the thalamus is considered as a relay station. All the sensations, doesn't matter, advanced sensations or primitive sensations. All the sensations have to come to the thalamus, so it is considered as a relay station. From the thalamus, third order neurons will start. Okay, actually, see, these neurons which I am showing you, these are the third order neurons. See, this is the third order neuron. Okay, this is the first order neuron. This is the second order neuron. Okay, there are 3 orders of neurons. From thalamus, always third order neuron will start. Okay, third order neurons will start. So from the thalamus, third order neurons are starting. So which nucleus of thalamus is receiving all the sensations, touch, pain, temperature, pressure, and all the advanced sensations are coming to which nucleus of the thalamus? It is ventroposterolateral VPL. So ventroposterolateral nucleus of thalamus is receiving all the primitive as well as advanced sensations. Done. Next, here what you are seeing is a famous question. Doesn't matter FMGE, NEET PG, INICT, USMLE, LAB, doesn't matter. Every exam, they will concentrate on this. What is this? Is Brown-Sequard syndrome. See, half of the spinal cord is gone. Gone. Means half of the spinal cord is damaged because of a stab injury or because of a bullet injury. Half of the spinal cord is gone. Now what happens? The patient is going to lose which type of sensations? Only remember two things. Whenever this hemisection, this is called as a hemisection of the spinal cord, half of the spinal cord is gone. Whenever this happens, see, this dorsal column pathways are affected, advanced sensations are lost, as well as this primitive sensations, anterior spinothalamic tract, lateral spinothalamic tract, both are gone. So advanced sensations are lost as well as the primitive sensations, they are also lost. Both advanced sensations, primitive sensations are lost. But important is, in this Brown-Sequard syndrome, which is called as a hemisection of spinal cord, on the same side of the lesion, for example, this is the right side, this is the left side. Okay, ipsilateral means same side. There is ipsilateral loss of dorsal column sensations. Okay, on the same side of the lesion, for example, if I have a lesion on this right side, or if I have a lesion on the left side, on that particular side, the dorsal column sensations, the advanced sensations are going to be lost below the level of lesion. Below the level of lesion, advanced sensations are lost. But on the opposite side of the body, the primitive sensations are lost. Okay, so this is the point I want you to know. In Brown-Sequard syndrome, both primitive sensations gone, advanced sensations gone. Primitive sensations are lost. From the opposite side of the body, see, anterolateral column sensations means primitive sensations, touch, pain, temperature, pressure. Anterolateral column sensations, the primitive sensations are lost from the contralateral side of the body. The dorsal column sensations, which are the advanced sensations, are lost from the same side of the body. Only remember these two at least. Okay, so now just tell me questions in Brown-Sequard syndrome. Tell me, in Brown-Sequard syndrome, sir, there is ipsilateral loss of advanced sensations like dorsal column sensations, advanced sensations lost on ipsilateral side. Contralateral loss of primitive sensations or contralateral loss of anterolateral column sensations. That's the touch, pain, temperature, pressure. Next, in syringomelia, question will be asked, if there is a cavity, which is developing in the spinal cord. Okay, if you have such a cavity, then it is called as a syringomelia. Even you can see here in the spinal cord, this is an MRI which is showing you the syrinx. Syrinx means a cavity developed in the spinal cord. Whenever there will be dissociative sensory loss. Okay, dissociative sensory loss will be there. Dissociative, whenever you see this word, one single word, dissociative sensory loss. Dissociative sensory loss means, see, the dorsal column sensations are not affected. There is no problem with the dorsal column sensations. These crossing tracts or the primitive sensations are going to be damaged. So, there is a loss of touch, pain, temperature, pressure. Primitive sensations are lost, but the dorsal column sensations are spared. Advanced sensations are spared. Only one point. Syringomelia. There is a cavity within the spinal cord in the center. Okay, in the center of the spinal cord, there is a cavity. Okay, if the cavity enlarges, more and more problems will add up. But initially, there will be dissociative sensory loss. The patient is going to lose touch, pain, temperature, pressure. But the patient is having fine touch, but crude touch is gone. Vibration is there, but pressure is gone. Okay, so that is a dissociative anesthesia. Now, after that, what else you should know? Look at this brain. Here, the central region which I am highlighting in this brain, this is called as a central sulcus. This is called as a central sulcus. Now, back to the central sulcus. Okay, back to the central sulcus. There is this pink color area there, no? This is called as a post-central gyrus. The sulcus is a depression. Now here is a gyrus, elevation. So, This is called as a post-central gyrus. That is the primary sensory cortex. Okay, in your body, that's the primary sensory cortex. It's a sensory cortex. All your sensations, touch, pain, temperature, pressure, vibration, all the sensations, whatever you are feeling, your sensations, where they are processing, all the sensations are processed in the post-central gyrus. The area number, Brodmann's area number is 312 MCQ. Brodmann's area number is 312. Now, this blue color area, this is called as the precentral gyrus. This precentral gyrus is considered as the primary motor cortex. Motor, it will control the motor movements of the body. Okay, so the primary motor cortex is present in the precentral gyrus, the Brodmann's area number 4 and 6. Precentral gyrus as well as the postcentral gyrus. One is the somatosensory cortex, other is the motor cortex. Next, other famous MCQ which you need to know is the law of projection. What is law of projection? It explains what? Law of projection explains the phantom limb phenomena. Okay, phantom limb phenomena. It is phantom limb phenomena. It is explained by law of projection. What is law of projection? In a simple way, let me tell you. I will give you the explanation. For example, now imagine you just cut open my cranium. You have cut open the cranium, skull vault. Now there is somatosensory cortex. There is this post-central gyrus called as the somatosensory cortex. With this electrode, you are stimulating different parts of the somatosensory cortex. Now, where I will feel the sensation? I do not feel the sensation here. I will feel the sensations from my hand. I will feel like someone is touching my hand. Or I will feel that someone is touching my leg. I will feel like that. Okay? No one is touching my hand. But if you stimulate any part in the somatosensory cortex, or if you can stimulate, you are not even stimulating the receptors. You are not even stimulating any touch receptors, nothing. You are simply stimulating maybe the first order neuron you are stimulating, or the second order neuron, or the third order neuron, or the somatosensory cortex. Anywhere in this pathway if you stimulate, I will feel that the sensations are coming from the receptor level. I will feel that someone is actually touching my hand. This is called as law of projection. Anywhere in this pathway, first order neuron, second order neuron, third order neuron, somatosensory cortex, anywhere in this pathway, if you stimulate, the person will feel the sensations from the receptor level. This is the law of projection. It is explaining what? It is helpful in understanding something called as a phantom limb phenomena. What is phantom limb phenomena? See, after your graduation, whenever you are working in the clinics, you will understand this. Imagine in the trauma unit, there is this one person who is having a severe crash injury. Now, you are amputing his, for example, lower limb. His lower limbs are absolutely crushed in an injury. Now, you are removing his lower limb. You have removed amputee. Now, he is an amputee. Lower limb is not there. He is only having one limb. One lower limb is there. The right limb is gone. Okay. After 10 days or 15 days, he is going to come to the clinic. He will say you, doctor, it sounds weird, but you know, I am feeling the sensations, itching sensations, pain sensations from my foot. From my foot. But foot itself is not there. There is no foot. There is no lower limb. But he can feel the sensations from the foot, pain sensations from the foot. Many patients who are amputees will say this. 70% of the patients will say this. How this is explained? There is no foot, but how he is feeling? Because still pathway is there, right? Foot is gone. But the second order neuron, third order neuron, still the somatosensory cortex is still intact. If there is any electrical activity in this pathway, okay, if there is any irritation in this pathway, what will happen is he will feel the sensations. So, the phantom limb phenomena, it is explained by law of projection. Okay, done. Completed, sir. Now, last, retina. You are coming last, retina. Okay, the special senses, retina. Retina have how many layers? 10 layers are there. In the retinal, 10 layers are there. You will study this in detail in your ophthalmology. But my point is, sir, what are the first order neurons, second order neurons and third order neurons? In this retina, who is considered as a first order neuron? The photoreceptor layer, this last layer, these rods and cones, these are considered as first order neurons. Okay, rods and cones are the photoreceptor layer. And the bipolar cells, we have discussed. Pseudo-unipolar neurons are seen in the dorsal root ganglion. Bipolar cells are seen in the retina as well as the olfactory epithelium. See that same bipolar cell. Okay, this guy. Okay, see, two poles. Okay, bipolar cells. Bipolar cells are considered as the second order neurons. Okay, and the ganglionic cells, these are the ganglionic cells. Okay, these are the ganglionic cells. These ganglionic cells are considered as the third order neurons. So now tell me, in the visual pathway, who is the first order, second order, and third order neuron? First order neurons are the photoreceptor cells. Second order neurons are the bipolar cells. Third order neurons are the ganglionic cells. Sorry. See, these are the ganglionic cells, right? The axons. These are the axons of the ganglionic cells. These axons of the ganglionic cells, so do you know what they form? A collection of the axons of the ganglionic cells are nothing but the optic nerve. So optic nerve, it is formed by, it's nothing but, if you cut open the optic nerve, what you will see? You will see the axons of the ganglionic cells. The axons of the ganglionic cells are the ones which are forming the optic nerve, the second cranial nerve. Okay, the one point which I want you to know. Now, so I have already said to you, the ganglionic cells are the ones forming the optic nerve, MCQ, that's the MCQ. Okay, that's why it's considered as the output cell. Optic nerve is coming out, right? This is the optic nerve. So this optic nerve is nothing but the axons of ganglionic cells. Next step, what you should know. See, this is the optic pathway. You know it. This is the optic nerve. This is the optic chiasm. These are the optic tracts. In the NEET PG, in the last NEET PG exam, which was happened, I think, almost 120-130 days back, this question was asked. Okay, I will tell you what is the question, but you should know. See, this is the area of optic chiasma. If optic chiasma is damaged, what happens? If optic chiasma is damaged, let me tell you. See, compression of the optic chiasm is going to cause what kind of vision loss? Vision loss will be there. See, on both the sides, the temporal vision, okay, the side vision, both the sides, the temporal vision is lost. So, compression of the optic chiasm because of maybe prolactinomas, the tumors, okay, the tumors of the anterior pituitary. See, if this area, optic chiasm, if it is damaged, what happens? If optic chiasm is damaged, the person is going to have bitemporal on both the sides. Half of the vision is lost. Half of the vision is lost. Okay. Next, this is the question which was asked in the NEET PG exam. This question: why optic chiasma damage will cause bitemporal hemianopsia? Not now in detail. Simple, remember, optic chiasma damage will cause bitemporal hemianopsia. Now, if there is a damage at this level, what is this? Optic tracts. These are the optic tract, right? Whenever this optic tract is damaged, gone. What kind of vision loss will be seen? Bitemporal hemianopsia? No. Now, whenever this optic chiasm is damaged, see, yes, now again, half of the vision is lost, but not bitemporal. One side, temporal vision is lost. On the other side, the nasal vision. If here is the nose, this is the nasal vision. In this side vision loss. In this side vision loss. So this is called as homonymous hemianopia. Homonymous hemianopia. Okay. So homonymous hemianopia, it is due to damage. Where the damage? Damage in the optic tract. Okay, damage in the optic tract. Optic chiasm damage. Optic chiasm damage is going to cause bitemporal hemianopia. Okay. Next, important MCQ, which I expect that will come in your exam, is lateral geniculate body. Okay, in this visual pathway, optic nerve, you know, see, this is the optic nerve. Optic chiasm, you know, the center point. After that, there is optic tract. This is the optic tract, you know. Now, where this optic tract is going? Sir, optic tract is going into an area called, let's see, all this optic tract. This is the right optic tract. Look here, this is the right optic tract. Where it is going? The right optic tract is going into something called as the lateral geniculate body or the lateral geniculate nucleus. It is made up of how many layers? 1, 2, 3, 4, 5, 6. 6 layers are there. I don't want you to know how many layers. Important point is layer number 1 and layer number 2. See, from the layer number 1 and layer number 2, who is coming out? So from the layer number 1 and layer number 2, this pink color pathway is coming out. A distinct pink color pathway is coming out. From the layer number 3, 4, 5, 6, this green color pathway which is coming out. So what are these two pathways? So there are two pathways which are coming out. From the layer number 1 and 2, magnocellular pathway is coming out. And from the layer number 3, 4, 5, 6, the visual pathway that is coming out is called as a PCP, parvocellular pathway. So magnocellular pathway coming from the layer number 1 and 2 of the lateral geniculate nucleus. Layer number 3, 4, 5, 6 is giving origin for parvocellular pathway. Now in your exam they will ask you, are these are visual pathways, magnocellular, parvocellular, doesn't matter. They are carrying the visual information. Which type of visual information? The magnocellular pathway, this is MCP not MLP, this is the magnocellular pathway. It is carrying information about the movement, flickering of the lights, okay, flickering, and the depth vision, the 3D vision. Okay, I can feel the depth in the vision, right? Okay, this is like little forward, that's backward. I can feel the depth in my vision. This is not like a 2D vision, depth. So, important points, information about the movement, flickering, depth are carried by the magnocellular pathway. The parvocellular pathway is carrying about which information? The color vision, colors, textures, fine details, small details. So, color, texture, and fine details are carried by the parvocellular pathway. Okay, so these are the important points about the lateral geniculate nucleus. 6 layers. Layer number 1 and 2 gives magnocellular pathway, 3, 4, 5, 6 gives the parvocellular pathway. Functions of the magnocellular pathway, functions of the parvocellular pathway. Important. Okay, now after this, regarding the ear, I want you to know. Okay, regarding the ear, what you should know is, look, this is the cochlea. We know, every student knows this is the cochlea. If you do the cross section of the cochlea, this is how the cochlea looks. See, there is this membrane called as the basilar membrane. Okay, there is this membrane which is called as the Reissner's membrane. Basilar membrane is there, sir. Reissner's membrane is there. The questions what they will ask you is, what is this chamber? Scala vestibuli, scala media, and scala tympani. Now I will tell you what the questions they will ask you. See, question number 1 by 1. What are the receptors of hearing? Most of the students will think cochlea is the receptor of the hearing. No, inside the cochlea there are these cells. Have you seen? These cells are the hair cells. Okay, these hair cells, especially the inner hair cells are of two types, inner hair cells and outer hair cells. The inner hair cells are the receptors of hearing. Rods and cones, photoreceptors, rods and cones are the receptors of vision. The inner hair cells are the receptors of hearing. Now, endolymph is secreted by, see in the scala media, here there is a fluid present. Okay, this fluid, it is secreted by stria vascularis. So, the fluid which is present in the scala media, it is called as the endolymph. The fluid which is present in the scala vestibuli, it is called as a perilymph. Okay, so look here, endolymph, it is secreted by stria vascularis. This is also a question which was asked in the NEET PG exam. Organ of Corti. Okay, in the cochlea, there is something called as organ of Corti. Look here, this is the organ of Corti. Okay, here you are seeing the organ of Corti. See, this organ of Corti, it is lying on which membrane? It is lying on a basilar membrane. That's MCQ. Okay, it's lying on the basilar membrane. In the endolymph, yeah, we know the stria vascularis is secreting the endolymph. In the endolymph, which ions are more in concentration? Potassium ions. Okay, so this potassium ions will actually activate. Whenever sound is coming, these potassium ions are responsible for the activation of the inner hair cells, depolarization of the inner hair cells. So that's why, see, everywhere in the body, sodium will cause the depolarization or calcium will cause the depolarization. Everywhere, most of the places, it's a sodium which causes the depolarization. But here, organ of Corti, the inner hair cells, they are little different. So depolarization of the hair cells is due to potassium influx. From where this potassium is coming? Potassium ions are highly present in endolymph. Okay. Now, scala vestibuli and scala tympani, these two chambers are there, no? The upper chamber, scala vestibuli and scala tympani. Actually, you are like, if you see in this view, they are looking like they are separated, but no. Normally, if I show you cochlea something like this, this is the cochlea, no, I am unwounding the cochlea. Okay, I am unwounding the cochlea. See, this is how the cochlea will be if I unwound it. Okay, untie it. Now, this cochlea is having how many chambers? 3 chambers are there. Scala vestibuli, scala tympani, scala media. See, in the scala vestibuli, who is there? Perilymph. In the scala tympani also perilymph. So, scala vestibuli actually it communicates with the scala tympani. So, there is this area which is called as helicotrema. So, scala vestibuli and tympani. Scala vestibuli and tympani communicate via the helicotrema. MCQs. Okay? Done, sir. And regarding the auditory pathway is also important. I am not teaching here. That will also come in the ENT, auditory pathway. Do you know the mnemonic for the auditory pathway? Guys, do you know the mnemonic for the auditory pathway? The mnemonic, sir. Do you know? It starts with the letter E. E. coli ma. Okay, E. colima, eighth cranial nerve. C stands for the cochlear nuclei. O stands for the olivary nuclei. Okay, E. colima. That's the auditory pathway. That's a mnemonic. Okay, you must and should go through it. Okay, that's a very important thing. And next important points about the utricle and saccule. See, we have discussed about the cochlea. Cochlea function completed. Next, what we have back to it, we are having this vestibule and semicircular canals. No, see, in this vestibule, there is something called as a utricle as well as a saccule. Okay, there is something called as utricle and saccule. So look here, in this vestibule, this is the area of the vestibule. Okay, this is the vestibule, not the semicircular canal. Before the semicircular canal, there is vestibule. In the vestibule, two compartments are there. Two compartments. One is called as a utricle and saccule. What is the function of this, sir? Cochlea is for hearing. What is this utricle and saccule for? I have written the U something like this, right? What is this? Horizontal. Horizontal. So this utricle is the one which is responsible for the horizontal linear acceleration. If you sit in a car, if you go forward or if you're going backward, even without looking, even with your closed eyes, you can still say whether the car is moving forward or backward direction. So this horizontal linear acceleration is going to be sensed by the utricle. And saccule, I have shown like a dollar symbol. This is also linear only, but vertical. If you stand in a lift, even without closed eyes, you can still say whether the lift is going upward or downward. So that's the vertical linear acceleration. So vertical linear acceleration is detected by saccule. Utricle detects horizontal linear acceleration. Now, receptor for linear acceleration. What is the receptor for linear acceleration? Macula. So in the utricle as well as saccule, in both these areas, in utricle and saccule, there is a receptor present called as a macula. Just like organ of Corti, just like inner hair cells, this macula is the one. See, macula is the one which detects the linear acceleration. How many types of linear acceleration are there? Horizontal linear acceleration, vertical linear acceleration. Horizontal linear acceleration is detected by the utricle and vertical linear acceleration is detected by the saccule. And whenever you are bending your body, that's the angular acceleration. Okay, in the three-dimensional space, if your body is being bent, that's the angular acceleration. Who will detect this angular acceleration? By the semicircular canals. You are having semicircular canals, no? The semicircular canals, it contains something called as crista ampullaris. This is the receptor. So crista ampullaris is the receptor of angular acceleration. Angular acceleration. Horizontal linear acceleration, vertical linear acceleration, and angular acceleration. Detected by whom? Completed. Okay. So one more point here I want you to know is, already I have taught you this, the gamma motor neurons. Where we have discussed, sir? Gamma motor neurons, A gamma fibers. A gamma fibers are the motor neurons going to muscle spindles. Okay, are the fibers going to the muscle spindles? I have discussed this with you. Okay, and alpha motor neurons. Okay, A alpha are the alpha motor neurons going to the muscles for the muscle contraction. Already I have discussed this with you. Here inside the muscle, see, inside this muscle there is something called as a muscle spindle. See, this muscle spindle is innervated by the gamma motor neuron. Okay, it's innervated by the gamma motor neuron. A alpha motor neuron is innervating the actin as well as the myosin. Okay, alpha motor neuron is innervating the extrafusal fiber. This is called as the extrafusal fiber. Actin and myosin are considered as the extrafusal fibers. These gamma motor neurons are innervating these fibers which are called as the intrafusal fibers. This is the intrafusal fiber, nothing but the muscle spindle. Okay, look here. Gamma motor neurons, they are innervating intrafusal fibers, nothing but the muscle spindles which maintains the muscle tone. So muscle spindles, one question guys, muscle spindles are innervated by gamma motor neurons. Muscle spindles helps in maintenance of the muscle tone. Okay, so that's the one point which I want you to know. Now, if you are really good, just single error questions. One nucleus, one answer you should say. Suprachiasmatic nucleus. Suprachiasmatic nucleus, tell me, it is maintaining what? It is maintaining the suprachiasmatic nucleus, circadian rhythm. Okay, the circadian rhythm is maintained by the suprachiasmatic nucleus. The suprachiasmatic nucleus is considered as the biological clock. It's considered as a biological clock. Means for every 24 hours, the same activities are going to be repeated. Okay. So the suprachiasmatic nucleus is considered as a biological clock and is the one responsible for the maintenance of the circadian rhythm. The lateral nucleus. Okay, Henry, yes, you are true. Excellent. Excellent, Yashank. You are also. It's true. That's the gamma motor neuron innervating the muscle spindles. The lateral nucleus of the hypothalamus. Right now I am talking about the different nuclei which are present in the hypothalamus. Hypothalamic nuclei is also very important for the exam. Lateral nucleus is considered as hunger center. Okay. So whenever you are not eating food, this hunger center is the one which is responsible for the creation of this feeling of hunger. Lateral nucleus. What is this ventromedial nucleus? Ventromedial nucleus, whenever you eat full of food, okay, now you'll feel, oh my god, I don't want to eat anymore. That's the feeling of satiety. So this ventromedial nucleus is considered as the satiety center. Satiety center. Okay, satiety center, MCQ. Now, anterior hypothalamic nuclei. There is a nucleus called as the anterior hypothalamic nuclei. So anterior hypothalamic nuclei, what it will do is cools your body. Cools the body. Means helping in what? Helping in heat adaptation. Heat adaptation. So whenever you are in a desert, okay, with the help of sweating, okay, this anterior nucleus of the hypothalamus, it helps in the sweating, it cools down your body. Okay, so adapting your body to the hot environment. And the posterior hypothalamic nucleus is exact opposite thing. Posterior thing is going to warm your body. Warms the body. Okay, helping in cold adaptation. Okay, helping in the cold adaptation. So these are the different nucleus which I want you to know. And one more thing, the medial forebrain bundle. One more thing is there, medial forebrain bundle. Medial. It is considered as a reward center. Okay, so the reward center is the medial forebrain bundle. There is this structure which is the medial forebrain bundle. Whenever the patient is, whenever the person is taking the drugs, or whenever the person is enjoying some activity, the reward, like you will have the pleasure center, right? So that's the medial forebrain bundle. So different nuclei are completed. Now, regarding the ECGs, only 4 or 5 important points. There are different types of EEG waves. No, sorry, not ECG, EEG. There will be alpha waves, beta waves, gamma waves, delta waves, and theta waves. When these waves are seen, see, these waves are nothing but the electrical activity that is happening in the cortex. The electrical activity that happens in the cortex is represented as the EEG waves. For example, see, now let's start from like this. In the morning, I just woke up. I haven't even opened my eyes. I am just sitting like this. I am not thinking about anything. I am not thinking about my life. I am not thinking about my girlfriend. I am not thinking about anything. Simply I am sitting like this, almost in a meditative state with my eyes closed. Now my brain activity is less, not more. My brain brain is, it's awake. I am awake. Brain activity is there, but less activity. So less number of waves will come. So alpha waves will come. So now alpha waves seen in relaxed state when eyes are closed but not sleeping. Okay, eyes are closed but not sleeping. Then alpha waves are going to come. Alpha wave frequency, how many waves will come? 8 to 12 hertz. 8 to 12 waves will come in a second. Okay, so the frequency of the alpha waves is 8 to 12 hertz. When eyes closed, relaxed state, almost in a meditative state, but not sleeping. Now, after that, I woke up. Now, daily day activities. I have to work. I have to think. Active thinking now. So, busy active mind. When you are active with the busy day-to-day life activities, then the beta waves will come. Beta wave means what? If more number of waves are coming, then it is called as a beta wave. If 8 to 12 waves, if they are coming, then it is called as an alpha wave. Beta wave means more number of waves are coming in a particular time. Okay, so beta wave frequency is 13 to 20 hertz. Okay, 13 to 20 hertz is the frequency of the beta waves. When the beta waves are seen in active mind, this is important, busy active mind. Okay, this beta wave is also called as, there is one more name, it is also called as the EEG desynchronization wave. If you want to remember, yeah, you can remember it. Next, after that, suddenly I am starting to thinking about my life. How my life, what I have to do about the FMGE exam. Imagine I am a student who is giving the FMGE exam. Okay, in 40 days, exam is going to be there. So intense mental activity, or I'm a scientist who is like, thinking on some formulas, hypothesizing the things. Very intense mental activity. So more number of waves will come. More number of waves, more than 60 waves will come now. So whenever the person is showing extreme focus, okay, extreme focus, like problem solving or cognitive processing, then the gamma waves are going to come on the EEG. Okay, gamma waves are going to come. So simply tell me, alpha waves are seen during relaxed state. Beta waves are seen during busy active mind. Alpha wave frequency is 8 to 12 hertz. Beta wave frequency is 13 to 30 hertz. Gamma waves are going to be seen during intense mental activity or focus. Okay, focused things. The frequency is going to be more than 60 hertz. Okay, next, at the end of the day, after this class, I will go to the sleep. You will also go to the sleep. Okay, so directly will you go into the deep sleep? No, first you will go into light sleep. Later you will go into the deep sleep, right? So light sleep means little mental activities, that your mental activity is going down. So see how many waves are coming. Only 4 to 7 waves are coming. You are going into drowsiness, light sleep. So theta waves are seen. So theta waves are seen during light sleep. Okay. Now when you are going into the deep sleep, now you are dreaming, deep sleep, sir. Only 1 to 3 waves will come. Okay. So delta waves. So delta waves are seen in the deep sleep. Light sleep, theta waves are seen. Delta wave frequency is 1 to 3 hertz. Theta wave frequency is 4 to 7 hertz. So EEG is also completed. Next, regarding sleep, two important points which I want you to know is, the sleep is divided into REM sleep as well as NREM sleep. See, all the like parasomnias. Okay, there are certain things called as the parasomnias. Let me show you here itself. The parasomnias. What are these parasomnias? Parasomnias are the abnormalities of the sleep. Okay, abnormalities of the sleep. So during sleep, you have to be like relaxed. You have to be relaxed. Absolutely, you should be happy, completely taking rest. But what if you are having night terrors? What if you are having somnambulism? The person is walking and going away somewhere. What if the patient is talking to himself? Bruxism, grinding the teeth, and nocturnal enuresis, passing the urine during, like, at bedwetting. Okay, so these are the abnormalities during the sleep, right? So all these parasomnias, remember, all of them, they will happen during NREM MCQ. All the parasomnias will happen during NREM sleep. I have taught you. Sleep is divided into how many types? Sleep is divided into NREM, REM. Okay, first important thing, in NREM, parasomnias. Okay, abnormalities of the sleep. What are the parasomnias? MCQs. What are the parasomnias? Here I have discussed with you. Somnambulism means sleepwalking, sleep talking. Bruxism is grinding the teeth. This is the MCQ. Bruxism is seen in stage 2 NREM. Okay, NREM is divided into many types. Stage 1, stage 2, stage 3, stage 4. Here point I want you to know is, sir, this bruxism is seen during stage 2 NREM. Okay, this somnambulism, walking and going away somewhere, it is seen, that's a slow sleep walking, it is seen during deep sleep, stage 3 and stage 4 NREM. So tell me, sleep is divided into how many phases? NREM, REM, sir. All the abnormalities of the sleep is seen when? Sir, the abnormalities of the sleep are seen during NREM only, not REM. Now next point which I want you to know is, difference between NREM and REM is dreams. When the patient is going to have dreams, during NREM or REM? See, dreams are present in both REM and NREM. Dreams will occur in both NREM as well as REM. But dreams are not remembered. See, remember something like have a mnemonic. NREM means non-remembered. NREM means non-rapid eye movement. I'm not talking about that. Remember it like NREM. Whatever the events happen in NREM, whatever the events that happen in NREM, the person cannot remember anything. Sleepwalking, sleep talking, bruxism, nocturnal enuresis. Tomorrow ask him, "Arey, what is this all? Like, you are wetting everything." He will say, "I don't know." Something like that. Yesterday night you are talking to someone, you are talking with, like, during the sleep, he will say, "Me? No, I'm not." He will say, "Yesterday night you are going somewhere, sleepwalking." He will say, "No, I'm not, I didn't went anywhere." So whatever the events that happens in the NREM are not remembered. Even the dreams are not remembered. But the dreams that occur in REM are remembered. Okay, so dreams are going to be remembered. Here, not remembered. In REM, dreams are going to be remembered. That's the one point which I want you to know. Okay. So REM, NREM, important points. And one more thing, which is, see, in REM, see this, all the muscles in the body during REM sleep, rapid eye movement sleep, there is a sleep called as rapid eye movement sleep. During this, all the muscles in the body are relaxed. So that's why sleep walking not possible, sleep talking not possible, grinding of the teeth is not possible. Okay. So the point which I want you to know is, sir, during REM, all the muscles in the body are relaxed. So parasomnias are not possible. Okay. So that's the point which I want you to know. These are the points. And the last slide for today. With this, the central nervous system topic will also be completed. Okay, the last slide, basal ganglia. Can you tell me now? This slide is for you. Can you tell me what is the function of the basal ganglia? What is the function of the basal ganglia? The function of the basal ganglia is stores this basal ganglia stores motor programs. Okay, basal ganglia, it stores the motor programs. Okay, how a motor activity need to be done? Cycling, walking, swimming, typing, writing, all these are the motor activities, right? How a motor activity should be executed, which muscles to contract, which muscles to relax. This information about a motor activity, see, I don't know swimming, I don't have the motor planning for swimming, but if I do go for training, yeah, that motor activity, that motor program will be stored in my basal ganglia. Okay, I don't know how to do the somersaulting. If I try, my basal ganglia, it will understand, it will learn, and it will store the program how to do that motor activity. Okay, so basal ganglia, the function is it stores the motor programs. Okay, sir. Now MCQ number 1, stores the motor programs. Basal ganglia, what are the components of the basal ganglia? The components of the basal ganglia are caudate nucleus, putamen. Both this caudate nucleus and putamen together, they are called as the striatum. Okay, MCQ, very, very important. Striatum includes what? Striatum includes CP, is the caudate nucleus and putamen. These are the structures which are present in the brain, the deep parts of the brain. This caudate nucleus and putamen is considered as the striatum. And it produces which neurotransmitter? It releases the inhibitory neurotransmitter, as the GABA. GABA is the inhibitory neurotransmitter. Okay, GABA is the inhibitory neurotransmitter. Very, very important. Lot of times this question has been asked. GABA is the inhibitory neurotransmitter. Okay, GABA and glycine. GABA and glycine are the inhibitory neurotransmitters. Okay, GABA and glycine. Glutamate is the excitatory neurotransmitter. I will talk about that. Anyway, globus pallidus, it is also producing the GABA, and substantia nigra, which is producing the dopamine, it is present in midbrain. Okay, substantia nigra, it is present in the midbrain, and the subthalamic nucleus, not the thalamus, subthalamic nucleus. There are 5 components of the basal ganglia. Tell me what are they? They are caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. These are the components of the basal ganglia. Out of these 5 components, who produces dopamine? Substantia nigra. The dopaminergic neurons are present in substantia nigra. Which nucleus produces the excitatory neurotransmitter? Glutamate. Glutamate is produced by subthalamic nucleus. This is also the MCQ. Okay, this is also MCQ. Okay, these are the components of the basal ganglia. Striatum consists of CP, caudate nucleus, putamen. Remember that. Okay. Now, here in basal ganglia, for your FMG, at least for your FMG, what you need to know is, sir, this basal ganglia, okay, there are 2 pathways present. Okay, there are 2 pathways present. There is something called as a direct pathway, indirect pathway. See, this is a direct pathway. What it will do? It helps in the motor movements. It will initiate the motor movements. Okay, it will initiate the muscle contractions. What this indirect pathway? See, whenever I need muscle contraction, yeah, muscle should contract. Whenever I doesn't need any muscle contraction, muscle should not contract. They should relax. They should be in a relaxed state. Okay, see, imagine there is this muscle. Muscle is there, alpha motor neuron is there, contractile apparatus is there, everything is there, but still it is relaxed. Who is keeping it relaxed? Basal ganglia will cause the inhibition. Whenever it is needed, the basal ganglia is the one which causes the contraction. Okay, so there are 2 pathways present. One is the direct pathway. It is the stimulatory. It stimulates the movements. It initiates the movements. But there is also inhibitory pathway. Whenever motor activity is not needed, What this inhibitory path, what this indirect pathway will do? Inhibits motor movements. That's the MCQ. Direct pathway stimulates the movements. Indirect pathway inhibits the movements. Okay, answer. And MCQ. Next MCQ. Dopamine is there, no? Dopamine produced by substantia nigra of the midbrain. Dopamine, what it will do? Dopamine, see, it's stimulating the direct pathway. It stimulates the direct pathway. But dopamine inhibits the indirect pathway. This is the question what they will ask you. How to understand this, sir? See, dopamine, what it is doing? Stimulating the direct pathway. By stimulating the direct pathway, what it will do? By stimulating the direct pathway, it increases the movements. It helps in the movements, it helps in the muscle contraction. But there is this disease called as a Parkinsonism. Okay, there is this disease called as Parkinsonism. In Parkinsonism, what happens? The dopaminergic neurons or the substantia nigra. Okay, the dopaminergic neurons in the substantia nigra are lost. So what happened to the dopamine levels? Dopamine levels decreases. So do you think direct pathway will be properly stimulated? No. When the direct pathway is not properly stimulated, do you think muscle contractions will happen properly? No. So now the patient is going to have echinacea or bradykinesia. It's very difficult for the person to initiate the movement because the direct pathway is not getting activated. The substantia nigra gone, dopaminergic neurons gone, no dopamine. Whenever the no dopamine, direct pathway is not stimulated. When the direct pathway is not stimulated, the initiation of the movements is difficult. That's why we say echinacea, no movement, or bradykinesia. Whenever this patient tries, he will have tremors. He will have the tremors. Pill rolling tremors will be seen. Okay, pill rolling tremors will be seen. So these are the things. And whenever the basal ganglia is damaged, basal ganglia, remember, first number one point, basal ganglia is predominantly inhibitory. Okay, it's majorly it is inhibitory. It's majorly inhibitory. See, most of the time, see, for example, when you are sleeping, all the muscles need to be relaxed. Most of the time, you need to have the relaxation, not the contraction. Right now, I am sitting. You need to have the relaxation. So, basal ganglia is majorly inhibitory. That's why, how sir, if you ask me, see, GABA. Okay, so cardiac nucleus is producing GABA, putamen is producing GABA, globus pallidus is producing GABA. Most of it is producing the GABA. GABA is an inhibitory neurotransmitter. So this basal ganglia is predominantly inhibitory. So whenever the basal ganglia is gone, inhibition gone, overactivation, unnecessary movements, unnecessary contractions. So damage to cardiac nucleus will cause abnormal movements in the body is called as chorea. C for C. Cardiac damage will cause chorea. Globus pallidus. Damage to the globus pallidus, a part of basal ganglia. Damage to globus pallidus is going to cause athetosis. Damage to subthalamic nucleus. Okay, the excitatory neurotransmitter thing. So damage to subthalamic nucleus is going to cause hemibalismus. Okay, hemibalismus is all this chorea, athetosis, hemibalismus. All these are the involuntary movements. Some are writhing movements, some are jerky movements, some are fast movements. There's a difference in involuntary movements, but simply saying cardiac damage causes chorea. Globus pallidus damage is going to cause athetosis, and subthalamic nucleus damage is going to cause the hemibalismus. All these are the different types of abnormal movements. So with this, all the important things which you need to know regarding the central nervous system. Okay, the central nervous system important things are completed. Hope the video is helpful. Okay, but before going to the exam, once go through all the rapid revision things. It's a highly integrated, not only just from physiology, the questions from the pathology will also be integrated. Hope you guys like the session. So, shall we take a break? Break in the sense, it's the end for today. Okay. Okay guys, see you for today. Bye-bye.